adolescent health services. Next. Our mobile approach is to just a snapshot of a community health nurse visiting a pregnant young girl. And I don't know if we can all see, but through the blue, you can see a protruding stomach. That's how far we have evolved as a program to meet young people in their setting where they are comfortable. So we don't wait again at the static point for them to come. We move out. Yes. We have other initiatives in school apart from the school health information system. We complement the GES to provide sexual and reproductive health in schools. And we have been able to establish 1,602 clubs in basic and senior high schools. We manage the school clinics, annual screening, and we have Adolescent Health Ambassadors Network. Before COVID, every year, the Adolescent Health Ambassadors Network meets with so many other students at a forum called, what's the name? AHA. Right, Adolescent Health Ambassadors Camp. Sorry, forgive me, yes. And it's always a week-long activity where we take young people through training, and they also support in training, and they learn a lot. We are hoping that the many people here will support us this year to bring that back on board. Next. Yes. So I've mentioned 2 platforms so far through our service delivery. That's the static, the community, and now the very last one, static and school. Now the very last one is the community-based. I've mentioned what, community, sorry. Safety net program. I think community starts with the Medachi. That's slide 20. Slide 20, yes. So this is just a snapshot of a young person with the training manual educator in the house of a young person, teaching her the danger signs of pregnancy. Upper left, see upper left. Upper right is just routine home visit, and I think he's sitting on a vaccine box or something, and all of that. Yes, let's move on. It's not so clear. The third platform, virtual, where most young people are, you conduct your life. Do all of you have TikTok accounts? Hello, Shakira and Co. You don't have? It's not true. Yes. So we have a mobile application called the Ghana Health Service You Must Know. The YMK is You Must Know app. We've trained 10 cyber counselors to provide counseling for all young people in Ghana, and we have SBC materials on the app. So you may not necessarily want to speak to a service provider, but you can read the materials or just type in a question. We have some FAQs there that can attend to your needs. We have the GHS Family Health mobile app, which is for service providers. It's a resource material for service providers. Move. So we also use that platform as part of our virtual reach to young people and service providers. Then we have our social media platforms as part of the virtual means that we use to reach young people. We have the Facebook, we have the X, formerly known as Twitter. We have the ADH Ghana, that's on Instagram. So very soon we will have our TikTok platform. This is just a snapshot of the e-learning platform and the courses that are on it, leveraging ICT, changing the way we work. We have evolved, we've grown. It's been 28 years. This is a snapshot of the school health information system. Yes. So they are used by school nurses, which we've mentioned. We'll look at some of the policy documents and SBC materials we've developed during the course of the 28 years. We have a job aid that supports nurses or adolescent health service providers to provide services or as a reference material and guide for service provision. We had an adolescent health training manual, which has been updated to the next picture we can see. And then again, it has been updated again. Back, please. I'm just trying to detail the evolution, so take time for me small. Thank you. Yes, then it has also been updated again to a facilitator's guide, all on the top. Yeah, all on the top. Then we have our PSSP guideline, from which we developed a training manual. And these two, the first two on the left, are actually coming from the facilitator's guide for young ambassadors, because we used to use that during the camps, but we've evolved and new information and new programs have come up in the adolescent health program. So we had to document these guidance as such. We have a resource manual for adolescent health for school nurses, which is under review currently. Yes, please. Yes, move, please. Okay. We have some of our SBCC, it's no longer IANC, SBC materials here. The You Must Know newsletter, the Adolescent Health Info Pack, which is currently in the 3rd edition. Yeah. Key achievements. For all of this, moving from where we were, bringing on board new programs, leveraging on ICT to reach as many young people as possible in Ghana and providing them with accurate and quality AYFHS, we have been able to steadily reduce the adolescent pregnancy rates through SRH education and services. And we have improved access to service delivery using the YMK platform, home visits, and other outreach programs, including nurses being stationed in the schools and even in the facilities. And we've been able to enhance literacy among young people, which empowered them to make informed decisions. We are not done yet, we are still on our way, but data shows that we are making strides towards a bigger achievement. And we've been able to advocate for policy change, and now adolescent health is recognized amongst our stakeholders. Key of that is the mental health of adolescents in Ghana, which was neglected, but now through advocacy, most stakeholders are buying into that. And currently we are generating evidence for designing interventions with or to improve uptake of mental health and SRH services in Ashanti, Greater Accra, and Eastern regions. I'll just show you snapshots of the data to buttress my key achievements. I don't know if you can see, but from 2019 to 2023, we can see a steady decline in the number of young people attending ANC. It means that the pregnancy rates have been reducing through our contribution. Pardon? When I'm done, please. Yes, and this is number of young people accessing services. If you remember, I said we have been able to reach many young people. And let me read or give you the figures from here. From 2019, we were doing about 394,795. There was a dip in 2021. However, even not looking at the figures from the graph, we have moved up 2022 and 2023. We have a few challenges. That adolescent health program is largely donor driven. So sometimes it's difficult to intervene as we would have wanted to. And there are still myths and misconceptions regarding SRH services. Ghanaians are conservative. We don't want to talk about sexual and reproductive health to young people. So it becomes a bit of a challenge. And then our way forward or future direction, we want to ensure sustainability of programs and services. We want to address disparities in access to health services among young people in rural and underserved areas. And we want to continue to prioritize mental health and well-being, integrate it into all aspects of adolescent health programs. And lastly, we still need to leverage more on technology and innovative approaches to reach and engage adolescents effectively. And all of this, although I've said that donor direction sometimes is a challenge, we would want to appreciate them. Next slide. Next slide, yeah. UNFPA, UKAID, DFID, UNICEF, WHO, they have reps here. WAHO, MSI, PPAG, our MDAs, GES, NYA, CSOs, NGOs, and academia like Prof. Otupri. So thank you so much for your time.
Thank you very much for the wonderful
Vera.
presentation.
Hey, please, Moxip. Please clap for Moxip. Who? Oh, MPC, clap for. Please clap for all MDAs. Clap, I beg you.
Clap, clap.
My job is at stake. Clap.
Whether they clap for us or not, we ask you questions.
Okay,
Please
please
ask
go
Prof.
ahead.
Okay.
Thank you very much. Sorry, thanks for the presentation. But I have just two issues to find out from you. The first one is on disability friendly of most of your initiatives. For the sake of inclusivity, I wanted to hear more on how most of the things you are talking about are being used by adolescents with disabilities. That's the first one. And then the second one has to do with the reduction in adolescent pregnancy. As you mentioned, that it has reduced from your achievements. That was the first one. And you indicated that with the graph on the ANC attendance. But I was trying to understand how.
Okay. We'll go back to that. Yes.
We'll go back to that.
Yes,
one.
he will go back
yes,
to
because
that.
it's not always the case that adolescents who are pregnant will be attending ANC. So if you use that data to say it has gone down, let us just check what is the latest adolescent rate in Ghana, and let's compare it with the previous year, and then we can see whether we have really done well or not, but not really with the ANC. That's what I want you to.
That's fine. So the inclusivity, yes, we have redesigned our, what's the name? The info pack into Braille for young people who are visually impaired. And we have a school clinic, especially in Cape Coast, a school for the deaf and blind, where we've stationed service providers who can both sign and support young people who are visually impaired. We have developed sign language modules and taking service providers through, not every service provider in Ghana though, but we have a majority of service providers being trained in sign language, and that's complementing MOH training service providers in sign language to cater to the needs of young people who are deaf. Deaf is accepted, sorry. Young people who are deaf, yeah. And let's see our facility-based data. That's what I used. The graph, the first graph. Plantain chips. No, plantain addicts. What's the name? Plantain chips addicts. Yes, plantain addicts. Okay, thank you. Yeah. So Vera, this is from our facility-based data. We use ANC as proxy, and that's not the only contributing factor. I mean, we have FP services. Right now we have comprehensive abortion care as well. So yes, they may not all come to the facility, but because we do not know, they may not. We don't know the numbers. this is what we will use as proxy. Thank you.
All right. Thank you.
Sorry, just to add to some of the questions, because some of the questions have been answered, but when we talk about the diversity still, how are we ensuring that the rural folks have access to some of these platforms, especially when we are talking about the e-platforms and other things, and accessibility of internet in these areas are challenged. And then you also talked about the various manuals and strategies that you have. How are you ensuring that the various NGOs and CBOs who are doing these trainings and developing different strategies and manual for ASRHR training are adhering to some of these policies and strategies? Because I know a lot of NGOs are doing it. How are we ensuring that the messages that they are sending out are in line with the policies and your strategies as well? Thank you.
Right, thank you. So rural folks on the use of our virtual platforms, of course, if there are internet challenges, it's out of what we can do. Yes, but because we have community health nurses, community health workers, and then the Medachinti activity in the rural communities, we want to leverage on that. Because as for internet challenges or having a smartphone, it's above us. Yes, the manuals and guidelines, I quite remember the very first manual, that's the NOGS, National Operational Guidelines, we disseminated and we distributed. Recently, I distributed again. Vera is a witness to the technical committee meeting where I distributed, and even Paul. And the other documents, that's for the peer support service providers. We have disseminated again and distributed copies, but currently we ran out of copies. That's why I did not carry some here. Usually, if I'm going for a meeting, I know I would meet people, so I carry those I can carry and continue distributing. But it's just a call to tell us that not so many people still have it, and the more we print out, the more we will distribute and disseminate. Thank you. Yes, sir.
Thank you for the presentation. I wanted to know, you mentioned myths and misconceptions as one of the key challenges you are facing. At the same time, you said the service have a communication strategy. So I would like, if you could elaborate further, what are some of the issues that you addressed with the communication strategy so that we can understand why myths and misconceptions still remain a challenge, why there's a communication strategy that the service is operating with?
You'd bear with me that although I would have come to preach to so many people here, out of 10, maybe 5 would accept my message, and 5 will still be thinking that is she being honest. So yes, we educate, we go down to communities, we talk to parents, we talk to community leaders, we talk to young people that SRH is not just encouraging sex or promiscuity, but it is to be informed, have an agency, and see yourself through school without any sexual issues. But not everybody takes the message. Typically, we were in Ashanti some time ago. Young people know that if they take contraception or if the boys used condoms, there will not be adolescent pregnancy. But here is the case, a parent has brought his or her daughter to a school in the nearest community, not in their community, pays for a month's rent, gives food stuff, she goes away and doesn't come back. Then the girl has to fend for herself, and these are true stories. The girl had to fend for herself. So in fending for herself, she got pregnant. We met them in school, and these were the stories they were telling us. So in as much as we are educating, we are making, for example, contraceptive services available. we have nurses visiting the schools and all of that, we still have challenges getting everyone on board our message. So that's what's happening. Yes. The study is actually on behavior change. Yes, we are using human-centered design for that. Yeah. Please, so do you realize that I said I'm representing the DG? Okay,
Hello.
Hetty.
Yeah.
Hetty, last one. Shakira, Mina, that's the last
Hi.
one.
Yes. Thank you very much for your excellent presentation. I have just two questions. The first one is on the challenges. The very first challenge was donor-driven, like number one. And I just want to understand like the background behind it. Is it that it's a call for the government to support like funding, or it's an issue with the donors, or it's an issue with the agenda of the donors, so that as we are here, we can address it? The second question was, I was very excited to see materials that have been produced with SBCC, because I'm interning with UNICEF SBCC unit. And I just want to understand, is it that the materials were made based on SBCC principles, or they are teaching them SBCC principles? I just want to understand like where the SBCC comes in. Thank you.
Hetty, I like that you want to address the donor-driven here and now. So it's two-tiered problem, you know. Sometimes the donor agenda is not the direction we want to go, but we need the money. So I need to train service providers in mental health. It's an example. Oh, the funds is for SRH. We are so so we have to go SRH direction. You get it? And it's again a call to government to also support the program with some funds at least, so that if donors have their agenda, we can still do what evidence is telling us, because young people have psychosocial issues we are not addressing. What does it take? We need to train people. It requires some bit of money to do that. Yes, and the SBCC materials were designed to support young people change behaviors towards seeking health, seeking behaviors. Yes.
So thank you very much.
Did you? Don't do
Yes, so don't worry if you can't refer. This is just a suggestion. If we can put mechanisms in place to track what other NGOs and CBOs are doing in terms of information sharing on SRHR, to ensure that they are going, or they are aligning with the policies and strategies, because it's very important, and it also contributes to some of the myths that you are talking about. The other question to you is the issue with GES and Ghana Health Service in terms of providing SRHR information in schools, where they are preaching strictly abstinence, and you are preaching other things in addition to the abstinence. We all know that, I'm sure when the report comes out now, you see the ages that are getting pregnant. Now, even menstruation age have reduced even to 9, or if I'm not lying, 8. And if these changes are happening, the children are becoming more active before the age we are thinking of. What are we doing to resolve that we don't think that at JSS, primary, secondary school, we should preach abstinence when the people know about all the nitty-gritties about sex and other things? How are we resolving that?
Right. For your first question, I think we have a technical working group, and quarterly, we are supposed to meet quarterly to give updates and provide direction if someone is veering off the lane. We've had that in the beginning of the year, and we would continue doing that. So that's Laudapo. Second question on GES. I'm grateful GES is here. So I would just let Reverend and Teacher Techi respond to the GES question, please.
Good morning. And acting DG, thank you very much for. But please also note that she has said over and over again that she's asking for the DG. The DG is not here, so please, you need to moderate the kind of questions that you ask her. And that's just aside. So this issue of GES preaching abstinence, and then the Ghana Health Service talking about other things. Yes, so the battle lines have been drawn, and for GES, we'll continue to preach abstinence. And also, that is also the reason why we have the school health education program that's SHEP and the guidance and counseling units within the GES service. And when the guidance and counseling coordinators in schools engage students over a range of issues, including adolescent reproductive health. And so when we do counseling around ASRH, and we observe that some students, and of course these are needs that people have. You understand? We cannot take it away from them. And so if it's observed that a particular student is very high around those themes, we'll do the counseling that we can do. And then if it gets to a certain point that we need to refer, they always refer to our Ghana Health Service partners, where they can visit the adolescent health corners, and they receive intense counseling from them, and then at that point that they can make informed choices based on their needs. You understand? So because Ghana Education Service, we have a certain mandate, and it is well spelled out and cut out. I remember a certain time when the two DGs from GES and Ghana Health Service met, we had a certain discussion around this team, and then we said that for us, we continue to preach abstinence, but when we identify students who have high need for some of these SRH services, we will refer them to the Ghana Health Service, where they have the expertise to be able to take them through counseling, and then they make their choices. So we will continue to do our teaching and ensure that all that the Ghana needs to be able to have a very well-developed adolescent, and for future is done. Thank you very much. I hope I have. Yes, my DG is not here, so please also that's a caveat. Yes, sir.
Thank you very much. My name is Divine. I was not here when the introduction was made.
Yeah. Okay, please go ahead.
Okay. My name is Divine, so people to call me Dr. Divine. I work with UNFPA. I've been quiet. I've been listening very well. Thank you for the presentation, Ghana Health Service. Thank you for the representation by the youth over here. But I realize that the youth are exceptionally too quiet here. This is your program. A lot of the questions are being asked for you. That is not the reason why you are here. You are not here to do this. You are here to really and being able to contribute. We want to know what are your needs. What is it that we are doing that is very good for you, that you are benefiting from? What is it that you think that we can improve on? These things are very important. That's why you are here. So I would encourage you to speak. And before I want this particular session to go off, at least let's hear from some of the youth. We want to know what are your needs. Are your needs being cared for and things like that? I believe that that's why Prof brought most of you. Prof, am I right? Yes, sir. That's one of the reasons why most. Yes. So we want.
Before you came, you were talking a lot. I'm sure your presence has.
Not at all. If you can speak in presence of Prof, you must speak when I'm there. So please let's be part of the meeting. We want to hear your contributions. We want you to play that key leadership role that you need to play. Very, very important for me. Thank you.
Thank you very much. So I want to find out. My name is Andrews from USAID Propel. I want USAID Propel Health Project. Yeah, I want to find out from GES. First, I want to understand what is the, because I think we have, I may be wrong calling it conflicting policies, but I think it's our real challenge. So, what is the motivation for sticking to abstinence only? I want to understand, because I think, you see, this thing is a national issue. And as far as at the highest level, we don't see eye to eye. All the activities we carry out, I mean, they are superficial, and I think that it's important that we get the policy direction right. So I first want to understand, your DG is not here. So I just want to understand what is sitting in that meeting where the two DGs sat. What's the motivation for the policy direction? Thank you.
Thank you very much. My brother, you understand that it will be very, very difficult for a non-professional or non-expert to attempt to do what he doesn't have the requisite learning or training for. And so if it comes to, you find out in a school that a boy or a girl has need in this area. Me, a teacher who has been taught to teach mathematics and English and RME, and I attempt to provide service in the area of reproductive health to an adolescent or a learner without any training from on SRH, how competent will I be to do this? That's why I said that when the school-based counselors engage students and we identify those who have high need for these services, basic counselor will tell you, refer to professionals who have the expertise, who have the equipment, and then who have requisite knowledge in that area. We do not want to attempt issues that we have no competence on, and then go and damage or destroy people. You understand? So that's our basic lesson. That's the motivation. That we don't want to destroy them in an attempt to provide this service that we don't have any, have the requisite knowledge and skills and expertise. Thank you very much.
I'm very hopeful hearing your answer, because then I think we have solutions to this if this is the motivation, because I think that there are modules, people can be trained, I mean, to be able to appropriately engage this sect of the population. So I think if it's about training and about expertise and all of that, I think a lot can be done to overcome that. That would not be a big issue from what I know. So I think there's a lot of hope if that is the motivation. Ghana Health Service, I know, have the expertise, and if there is real integration, I think that collaborative effort can be used to overcome this. This is really it shouldn't be a challenge for us. I want to mention that the issue of national family planning, how will I call it, engagement, currently, which is happening, the development, hopefully for implementation. I'm referring to the Ghana Family Planning Costed Implementation Plan. It's supposed to be a national document. And as we know, for FP 2030, obviously, Ghana Health Service has stuck out its neck to reduce, I should say, reduce the unmet needs, right, of adolescents. And they are looking at from 57% to 30% by 2030. So that's a good direction. I believe that since it's UNFPA, they are clearly represented on the TWG of the activity. Talking about SBCC, again, Ghana Health Service, Ministry of Health has stuck out its neck clearly, talking about how to churn out specific SBC messages or strategies towards the the populace. So I think there is good direction in this, and it's good to hear that there is a lot of progress, and we can achieve more. But I would request that we look at the collaboration and how to seriously integrate GES policies with Ghana Health so that we can sing the same song. Thank you very much.
We will do that, but currently we would provide the services out of the school premises. So our service provision is either on-site or through referral. So we will let GES, Ghana Health Service, rest for now, and we'll provide sexual and family planning services out of the school premises till we are able to. If not, it's just always, or it will always be through referral for now. Right? Thank you. Shaki. Okay, yeah. I wanted to say I will not talk again, but I mean, my fair lady wants to say something.
Okay, please go ahead.
Please, about the public education. The adolescents that receive formal education are being taught on the sexual and reproductive health and their rights. What about those that don't receive formal education, the uncivilized ones? So how do they receive the education about the sexual and reproductive health and rights?
So we have outreaches. The community health nurse goes to the communities to educate. We have adolescent health corners. We have community-based adolescent health clubs. We have the peer support service providers. Currently, it's not nationwide, though, but we have in about 7 regions. And these are all efforts to reach the father's girl who is not in school to receive the SRH education. But basically, community of nurses and community of workers are all over the country. I still know that some girls will be missing, or some girls will still be very far away, but we'll try and reach all of them. And that's why you are also here. If you go back, gather the girls that are not in school, call Amadokas, then let's start educating them. That's why you are here. You are ambassadors, okay? It's not just to listen and go. It's to spread the message. Are we clear? Yes.
Okay.
Please, about discrimination. Some people, some nurses, they don't want to teach people that are not educated. And also, for example, the Kayai, they are in the markets. Some people doesn't want to talk to them. And also, how would they also receive their education?
Which people? The ones the nurses don't want to talk to, or who? Kaya yes. The nurses don't want to talk to Kaya yes. Okay. They are stubborn nurses. I'll deal with them. Yeah. But we have been training our service providers on adolescent and youth friendliness. This is just a call to action that it means that either nurses listen to us, but when they go, they drink water on top of it, or we haven't reached enough nurses, and we are going to do that so that the Kaya yes and those who are not in school receive messages. Yes. Thank you.
Thank you very much. We'll quickly move to the next activity on the program lineup. So you are not even ready for us yet. Like, we, the young people, are coming on board. So stay actively and listen to us. So we have a pact of 5 sessions today, which I'll be moderating with the young people. So they are going to be talking. So the first section.
Okay. Good morning, everyone. Please, I'm Elizabeth, and I'll be moderating with Shakira today for the first section.
Right. So we're going to be moderating on why Ghana is selected as an exemplary country for the ASRHR project. And we're going to be engaging Professor Ismond to tell us or present to us why Ghana has been selected as an exemplary country for the ASHA project. Prof, please, are you ready? Co-moderator, where are you from?
Please, I'm from. Please, okay, I completed this year. I completed JHS this year. Please, yes.
Okay, so just to say, we are, including myself, we are from ages 12 to 19. Just so we don't have to mention our ages because we are shy. So we are 12 to 19 years. We are all adolescents and young people.
Thank you very much, Shakira. Good morning, everyone. And allow me to do this presentation on behalf of Gifty. It is important to know the background to why we are meeting here today. The ASHR project stands for Adolescent Sexual and Reproductive Health and Rights Project. And it's a project funded by a section of the Bill and Melinda Gates Foundation. So in the foundation, the big foundation, each of them, Bill and Melinda, have their individual interests, and they run foundations that support those interests. And this is under Bill's office set of projects that office funds. So the Exemplars in Global Health, which is the name of the project that Bill's office funds, they decided that the best way to go to scale is to look at what somebody else has done before and just to learn from that person instead of going to do all the things that have to be done. So if they are exemplary countries, then we learn from those exemplary countries, and everybody adapts what they've seen to their context after collecting a little bit of data. Next, please. So the Exemplars project has a very wide coverage. So the topics range from, I'm sorry, the LCD is not so clear so we can see it, but it ranges from vaccine delivery, under 5 mortality, and this is all about child health. It's about young children. It's also about maternal health, health services delivery, and other topics. So across here, there are various topics in different areas, health areas. And the individual programs within the broader health services are put up here. Now, I colored where Ghana features in red. So you can see that under the nutrition program, Ghana has been identified as an exemplary program as far as stunting is concerned. So Ghana is said to be making some progress, or remarkable progress, that other countries can learn from. Then, under COVID-19 response, again, you can see Ghana in red. So it meant that as far as COVID-19 is concerned, despite all the statements that some of us made, Ghana is recognized as having put up a great response. Under primary health care, Ghana appears again. That is without doubt. Our primary health care approach has been very good. In fact, Ghana is one of the countries that has been named to have universal health coverage. And the idea to work under the new initiative that will see strengthening of the health service at the sub-district level, it's a very great idea. And finally, there's also the digital health. As you've been told, the Ghana Health Service is doing quite a lot of work as far as e-health is concerned, both training and in service provision. Now, the current project that we are talking about falls here adolescent sexual and reproductive health and rights. So there are 1, 2, 3, 4, 5, 6 countries that have been identified as exemplary as far as adolescent sexual and reproductive health is concerned. And the reasons why they were selected are what I'm going to present now. Next, please. So the exemplars program has these 3 big things that it does. It conducts research, synthesizes the findings, and then drives impact, especially through dissemination activities and then web platforms. Next, please. For the women's health cluster, the adolescent sexual and reproductive health and rights finds itself in the middle. And the lead research partner is AFIDEP, based in Malawi. And the donor for the project, even though it's under the EGH, is a large anonymous donor. Whenever I hear large anonymous donor, I wonder, why then say there's a donor at all if it is anonymous? You don't want your name to be mentioned, yet you want us to call you anonymous. So Ghana happens to be one of the countries that was selected under this initiative. Next, please. Next. The key questions that the project seeks to ask are, what is the role of the contextual factors? Contextual, as in surrounding factors, the environmental factors. So factors such as policies, legal frameworks, socioeconomic factors, those things. Those are the things, they are enabling factors that enable all the other things to work within a supportive environment. So if the policy is great, then it will allow for things to happen. So for example, if we say that you can't talk about, or teachers can't talk about sexual health in the classroom, then it won't happen. The next thing is that the health system is a great way of delivering health services, probably one of the greatest ways. So the health system, what has the health system done to ensure that we have reached this so-called remarkable stage in the adolescent sexual and reproductive health? And what are the specific interventions? But then how are we treating the vulnerable adolescents? There was this issue about adolescents with disabilities. How are we addressing that? We are also looking at how we address the underserved adolescents who are not in education, any training, or have other challenges such as being young, an adolescent, pregnant, not married. How do we provide services to these disadvantaged populations? And then looking at how these effective interventions can be adopted for other countries and within countries to scale up. So even though Ghana has been identified as a great country as far as this subject is concerned, there will definitely be regional or subnational disparities. And we need to learn from the findings in order to make sure that the regions that are not doing so well, we can work with them to improve their indicators. Next, please. Next, please. So in the 6 countries that were identified, these are the research partners that worked with AFIDEP. In Ghana, it was the KNUST School of Public Health. Next, please. For the ASHA project, the topics that you see here, or the bullets that we see here, define the scope that the project was about. For us, particularly, this statement, as part of the definition of adolescent sexual and reproductive health and rights, is to ensure that all individuals have a right to make decisions governing their bodies and to access services that support that right. Next, please. This is the conceptual framework that guided the study in the 6 countries. So we identify a national context where all these factors influence the various things that happen subnationally at the household and community level, and as far as government programs and policies are concerned. They influence the health system, which in turn influences individual behaviors and competencies that result in the outcomes of interest. And for us, the pregnancy rate of adolescents, as depicted by the birth rate, pregnancy loss, and induced abortion rate, was of interest. Next, please. How did these 6 countries get to be selected among all the countries that are in the low and middle income belt? Well, these 3 approaches were used. So a regression analysis using fertility rate as the outcome of interest, and then representative filters, and then heterogeneity checks were used. Now, for the 6 countries, or for all countries, low and middle income countries, this is the average performance, right? And the countries that fall below average were selected. So India truly was exemplary. Well, not all of India, just a state in India. The truth is that conducting studies in a country that has about 1.3 billion people is very difficult. So usually Uttar Pradesh is used as an example for India because they have some of the worst health indicators that you can think about. And so there's Rwanda, Ghana, Malawi, Nepal, and then Cameroon. Rwanda has a certain very funny indicators. And as we go ahead, I'll show you those indicators. Next, please. So currently, this is where we are. Of the 4 steps that were developed, we are currently at the level where we are packaging and dissemination. So this is one of the dissemination and learning activities that we have planned for Ghana. Next, please. These are the methods that were used in one graph. So I will focus in my next presentation on this aspect, the quantitative analysis. That gives you data or quantities or figures to explain how the current situation in Ghana should be viewed. And then we'll also have a presentation that tells us about the qualitative component of it. The adolescents here, we spoke to adolescents similar to the ones who are here. And we've also had this policy and program analysis review and the desk review of all the things that have been documented about ASRHR in Ghana. Next, please. So for the next few slides, I will just give you an overview of the situation as it appears across the various countries for some of the indicators of interest. So we start with adolescent marriage. So the proportion of young women that are married using DHS data. So the quantitative component of the survey or the project used secondary data collected by DHS, MIX, and all the nationally representative surveys that you can identify, including PMA. For the adolescent marriage rate, notice that Rwanda is very, very low. Rwanda is very strict on adolescent marriage. It's actually a crime. It's criminal to be married under 18. And so even if they do get married, you wouldn't know. They wouldn't tell you when you ask them in a survey. And as DHS has reported, in some countries, including Rwanda, it appears that all the adolescents have been trained how to respond to surveys. So they give you the same answers or very, very similar answers, and it's difficult to differentiate between them. So there are many times when I'll say just ignore the Rwandan figure. This is one of the times I'm going to say it. So ignore this figure. But then you can see that Ghana has a fairly good figure compared with the other countries. Then let's move on to the median age profiles. So the median ages for women aged 25 to 49. And first of all, let us look at what happened when. So median age at first sex. Notice that in Cameroon, it's very low, relatively. Now, in Cameroon, they have a culture that encourages that activity. And that is how come it's that low. But Ghana follows after that. And notice that in Ghana, as we all know, as soon as you get married, we are expecting you to deliver, so to have a breath. And maybe for the adolescent or for other women, it may be the pregnancy that may push you to get married. So, but in general, as soon as you get married, we start counting the days. So you will realize that the median age for first marriage and first birth are very closely linked. Abortion legality. So the Institute for Health Metrics and Evaluation has an index that it calculates to report what it calls abortion legality. So the higher your index, the more legal abortion is. And you will notice that in Nepal, it's 100%. Ghana follows closely with India. Our abortion law is one of the most liberal across the globe. And in 2018, in a national representative survey that we conducted looking at abortion in Ghana, we could report a very accurate picture of the country, because even though abortion is stigmatized, the people don't want to talk about it, depending on how you ask your questions and whom you talk to, you will get the answers that you need. And then finally, looking at starting and ending adolescent sexual and fertility rate, also by the same institute. So they use two groups, 2000 and then 2019, and looking at the drop in rates. Where's Ghana? This is Ghana. What color is that? I think that's dark color, right? So this is how well Ghana has performed as far as that indicator is concerned, compared with her, compared with this subgroup that was studied. Next, please. Next, please. Now, we will explain this a little bit better in the next presentation, but it is the Oaxaca blinder decomposition analysis that was performed by the IHME to identify the quantitative drivers of decline in adolescent pregnancy across the various nations. Now, this decomposition analysis is a regression analysis, and what it tends to do is to explain the differences between two groups. In Ghana's instance, the first group was the group of 2000, the DHS around 2000, and then compared with the DHS of 2022. Now, what happens is that the differences between the two groups that were studied for Ghana, you see it's only a little bit. Now, it shows the decline. The baseline proportion for the decline was 14% in Ghana. And currently, it is not much lower. And that is how come that difference, the observed difference, is that low. In other countries, the difference is much bigger. And having identified that there's a difference, then it goes ahead to explain the difference, why the factors that contribute to the difference. Unfortunately, the methodology is not able to explain all the differences. So sometimes you will realize that the difference explained is not equal to the difference identified. But then they will use other methods to explain that difference, including cohort survival analysis. Next, please. Next, please. Here, we are looking at the various laws, supportive environment that help to impact fertility rate among adolescents. Now, if you look at this side of the slide, we are looking at changes in adolescent behavior in terms of marital status, and then first sex between baseline and end line. Notice that, where is Ghana? Ghana is the bright green, right? So there is a change, there's a drop in maternal or marital status. In other words, a smaller proportion of adolescents are getting married in Ghana. And also the age of first sex has also dropped in Ghana. And these all contribute to a reduction in the adolescent specific fertility rate in Ghana. Next, please. Next, please. Improvements in education is a big driver
of lowering the fertility rate among adolescents. This has been known for a long time, but the specifics are only now being described. So it's not just gains in education, and I'll come to that. So even though all the countries have aspects of this comprehensive sexuality education in schools, our country, Ghana, as I speak right now, I am reliably informed that the discussion is currently going on at the National Population Council with the lead, and that document has not yet been finalized. So in Ghana, we don't have this. We have reproductive health being taught in schools, but not the comprehensive. But I wouldn't make too much noise about that now, because all the other countries don't have what is truly CSE. Everybody has a nuance that best suits the person's context. So it makes sense that Ghana is going in that line. Now, looking at the years of education, baseline, where is Ghana? The bright green. Look at the difference. So it's about 1.5 on the average years of education increased. And this has a very, very important driver influence or driver factor for the reduction of the adolescent specific fertility rate. Now, in all the countries, they have worked to increase education, but Ghana's is remarkable. Okay, in a country like Nepal, there's no doubt that they've increased years of education, and that they raised the secondary school education from 43% in 2000 to 81%, double. And the changes in their fertility rate have also gone down. So education, as we shall show in the next presentation, is a big driver of bringing down the fertility rate among adolescents. Next, please. The countries have seen improvements in primary and secondary school attendance, but notice that for the secondary school attendance, Ghana now has the free SHS, right? Where's Ghana? There's Ghana. So we lead the pack. Currently, we have the largest number of students or adolescents in SHS ever since the history of the country. We've never had that number in school. Unfortunately, when I requested the exact data from GES, they wouldn't produce it. I was asked to go to the Minister of Health and Minister of Education, and they sent me backwards and forwards and backwards, and I don't have it. Now, the data that we used was from the 2022 DHS. What would have happened if we had figure for 2024? Probably it would be better. I don't know. But this failure to share data is a big issue. We needed to use factors such as the salaries that the teachers have. We also needed to look at the number of classrooms that were available and housing, and all that data. It only comes from MOE. There's no way we can have that. If it's already available, why go to the field to collect that data? Next, please. Health system strengthening. All the countries approach or use similar. So youth-friendly health services is a key driver for all the countries. But if you look at Ghana, you can see that all the measurements have sort of increased for all the types of women, the ever married, the never married, and so forth. And the data came from the DHS and the mix. Ghana has made impressive progress across the years. Next, please. Next. So the key drivers that we identify for across countries is one, formal education. And when I present the quantitative data, you will see the details of how much education can change the fertility rate among adolescents. Keeping girls in school, especially girls in school, is one way or a key driver of reducing fertility among them. Then the environment, the supportive environment is also extremely important. And finally, strengthening health systems. So when we come to the details of the quantitative analysis, you will see the approaches that were used to be able to measure the changes that we are reporting. Thank you very much.
Okay, thank you very much, Professor Ismon. Please, anyone with any question or comments? Okay. Please.
Hello? Hello?
Please, someone.
I'm not sure if my mic is working. I can shout. Hello? Great. Thank you very much for the very comprehensive presentation. I love the graph, the numbers, the figures. It puts everything in perspective. I just have a few questions on the presentation. So there was a slide on adolescent pregnancies, if I'm not mistaken. Where we looked, not adolescent, yeah, adolescent marriage. And you took the data from DHS. But then the indicator at the top was percentage of young women, 20 to 24, that are married. And I don't know if it was an oversight or it was used as a proxy for the percentage of adolescents marriage, because 20 to 24 is well beyond, not well beyond, but like out of that scope of adolescents that we talk about. And I was trying to find, I did some work for a consultant at the regional office on some of this data. I was trying to find the sheet because I also faced the same challenge you faced on getting data. Like most of the data I got was like 2017. So I'm very excited to see like the data that you collated. So if you can address that for me. Secondly, you mentioned that for India, they used a town as a proxy. A region as a proxy. I was just curious about Ghana. Did we do the same, or you just used the DHS? So it was like a national, like, are we looking at national data, or Ghana used certain areas or regions as proxy so that we get everything in a better perspective? I think those were my questions and concerns for now. Let me just be sure. Yeah, I think so. Yeah, and then, sorry, the last one was the marriage age for Ghana dropping. I'm just wondering what parameter was used for that. Was it from the Ghana Demographic Health Survey, the recent census, or was it like the legal marriages that were, I don't know, that are in courts? Like what was used to say, like, you know, marriages were down? Because I know in Ghana we have different types of marriages, and then sometimes people cohabit. They may be cohabiting, not necessarily married officially or formally. So I just want to get that perspective. Thank you.
Thank you very much for your questions. The graph that you referred to, the young people's age was used as a proxy. The details will come in the quantitative analysis. We will take it for the adolescents and we'll break it down into two, the young adolescent and then the older adolescent. And you realize that the older ones are getting more pregnant than the younger ones. For the representativeness, the data, as I said before, the data for Ghana come from the various national representative surveys that have been conducted in this country since 2000. So the DHS, the MIX, the PMA, all those. And then finally, the marriage age. It is not that the marriage age has come down, but the proportion of adolescents that are getting married has come down. It's from DHS.
Sorry, I missed two things. So the data used for Ghana was the DHS, like the whole Ghana, wasn't
DHS makes
okay.
PMA over the years, starting 2000.
Years. And then the marriage, I was not asking about the age. I was just wondering, like, what parameter was used to count marriages. I don't know if did you use, was it just DHS data, people reporting that yes, I'm married, no, I'm not married, or it was like maybe you couldn't get it from them, so it was like you used court documents. Did you like? That's what I'm asking, not the age per se. Like what
All
was
the
used to-
information
Yeah.
report, all the
Exactly.
indicators report are based on secondary analysis of DHS data,
Okay.
mixed data, and PMA data starting 2000. Ghana has a very good number of nationally representative surveys, so there's no point in going back to collect data.
Flaw, but for the I'm really sorry, for the
I help you?
age limit, the age for the older the 20 to 24 years that are getting married, that was used as a proxy for the adolescent marriage, the one that was shown, and you said it was 10.6. I'm just wondering what the issue is with 10 to 24-year-olds getting married, because maybe from a health perspective, usually we would want you to have your first child before the age of 30. And in our African context, when you start hitting that age, they're encouraging you to get married and have your children, because then the complications are less. So older complications, younger complications, in between is fine. So I'm just wondering, was it just the availability of data, or was there a reason for that particular age group being used as the proxy?
Details will come when we have the quantitative
Okay.
presentation.
Thank you.
We will not eat the fufu and leave the soup. We'll eat it together.
Okay, Prof. This is just a point of correction. The Ghana Reproductive Health Guidelines is not CSE. Ghana, we call it the Reproductive Health Education. It's been completed, and we have the National Population Council has submitted it to the Ministry of Education for the minister to approve. And so we are waiting for that, but according to NACA, it's not going to be a standalone document where they will teach it alone. They will gradually add it to other curriculum or syllabus until they come out with a standalone one. And so, as they said, I think it's already in progress, but the minister has not yet approved, and so we'll find out where it has reached before we use it. Thank you.
What's
Reproductive health education guidelines. Instead of
instead of CSE?
Yes, instead of
Yes,
CSE.
ma'am. Okay, but the content.
Yeah, it has all the content that we need to be inside.
Okay.
Maybe it's just some few ones that are different from other countries, and that is why we call it the reproductive health education document. Thank you.
Okay.
Yes, thank you very much, Prof. Very well researched topic. So much information available there for us to use. I just want to, I hope I'm not eating the pudding before, but then just a quick one. I think that most of the indicators that we have as a country, we're doing quite well from what you found out. And this is actually being supported by the all the research, national research, and the service that we have. If you look at all of them, they are good. But my worry is that we still do have a lot of challenge with maternal mortality. We still have quite a very significant amount of our women dying, about 860 a year, dying because of maternal mortality. And most of these, not most, but quite a significant number of them are adolescents who are pregnant and had to die. Others also do have some of these lifelong diseases or complications because of childbirth, like fistula and things like that. So my question is that how are we able to explain why we still have some of these good indicators, but then our maternal mortality is still very high? Any ideas why we still do have that? Because the challenge is that our maternal mortality is very high, ANC attendance is high, school delivery is high. Name them, they are still high. But so, what really do we need to do as donors? Where do we really need to focus attention to make sure that we bring the maternal mortality down? Thank you.
You and I have had this discussion before.
Yes.
If the rest of us are interested, I'll talk about it. You see, there are components of the health system, right? And one level of service delivery is the sub-district, the health center. The health center is the place where a lot of us go to deliver. That's what we have. And unfortunately, it is the weakest link in the chain. We do have the right number of midwives. In fact, internationally, we have the required midwives per delivery. We are even better than what the WHO asks us to have. When you look at the comprehensive EMOC services, we have higher than required. But when you come to the basic, we are terrible. Now, I wonder how we managed to build the comprehensive and forget about the basic. Because as I was taught in school, when you get the basics, the complications are no difficult. So the basic component that we should have, we don't have. It's zero, virtually zero. In fact, it has fallen from, I think, 7% to 5%. All right? Whilst the comprehensive has increased. We are over 100% with the comprehensive. So we have got it wrong there. And we are hoping that this network of practice idea would fix the gap that we have at the sub-district level. We strengthen the CHIPS. We're using a life cycle approach, a life course approach to home visits, but we haven't strengthened the health center. And that is where the problem is. Once we fix that, we will see a drastic change. The surveys show that at the health center, the human beings are there, there are no equipment. No medications are not there. Thank you.
Is that all? Okay, please, thank you all very much. So I would pass on to the next section.
Good morning once again. Please, my name is Mordecai Adi, and I'm the co-moderator for this section, and I'm doing this with Shakira. So please, Shakira.
All right, so we'll have our second session and then we'll go on break because the young people say they are a bit thirsty and hungry. Okay, so we'll quickly call on Professor Emmanuel Nakwa to give us a presentation on survey objectives and methodologies used for this project or the ASHA project.
Hello. Is the person around? If not, then we can take an earlier break and then come back.
Hello. they smoke cannabis. Doctor say make a pop one of this. Make me fly like say I'm Aladdin. Come bring some kind melodies. Oh, mama, myself no do pass like this. So many things inside of my gin. I slide down the beatings, the beatings.
good afternoon. Please welcome from that quick snack break. I'm your co-moderator for this section, and I'm in the person of Mordecai Adi, and I'll be doing this with Shakira.
Right. So for this session, we're going to have a presentation from Professor Emmanuel Makwa, and he's going to be explaining to us the surveys, objectives, and methodologies of the ASHA project. Prof, please, are you ready?
I am ready. Welcome from our short snack break, and I hope I'll be able to keep you awake for the next 15 minutes. So my presentation is about how we conducted this project work, or how we conducted the research, adolescent sexual and reproductive health and rights exemplars. Next slide. So this is going to be the outline of my presentation: objectives, research questions, conceptual framework, the scope of the study, data collection and analysis. Yeah, get it. This one's white. Okay. Yeah. No, I have a pointer in my bag. So at the top of it, you get it. That will be helpful. All right, next slide. So as already mentioned by Professor Tupri, the objectives of our study, just to re-echo, our objectives were to identify individual, household, community, the health system factors associated with adolescent sexual and reproductive health rights outcomes, identify compositional and behavior drivers of change, and to investigate geographical and other inequalities in these adolescent groups. Next. All right, so to address the objectives, we had research questions that guided our research, and what is the role of consensual factors, and this was already explained by Professor Tupri, the positive outlier countries and how the countries were selected, and Ghana was also selected as part of the countries that have demonstrated progress in adolescent health. So I will skip this. So this, the research questions that we are trying to answer, and the methodology that we use in addressing the questions is what I'm going to outline in my presentation. Next slide. All right, so to be able to address the research questions very well, we came out with a consortium framework to guide the research process. So we looked at the national context that was broken into the governance, the government policies and programs, the subnational level, and household and community. And then in the health system, we have access to sexual and reproductive health rights services for adolescents, the quality of the service to prevent and manage pregnancies. And then at the individual level, we look at aspirations, behavior, and then the intermediary outcomes that links to our major or our main outcomes. That is the birth rates, the pregnancy loss, and induced abortion rates. Yep. So the study was a nationally representative study. We grouped the regions into three. That is the northern zone, the middle zone, and then the southern zone. Greater Accra didn't fall in any of the zones because we classified that as a special group where we only focus on conducting key informant interviews in Accra, in Greater Accra. Next slide. All right. So our methodology focused on trying to answer the outcomes. So what we did was to do a literature review of the programs and policies. We also looked at, that we say is a DEX review. And then we went for policy and program documents analysis. We did a policy and program analysis. Then we did a quantitative analysis looking at secondary data, and then a qualitative analysis where we spoke to the adolescents themselves. Now, to go into details based on our consensual framework. So the first question was, what is the role of consensual factors in influencing adolescent and sexual health, including preventing, managing unintended pregnancies, and reducing fertility among adolescents? So we looked at the demographic, the political, legal, and economic, the social culture, gender relations, religious and civil society, the private sector, and most of this was based on our DEX reviews. Next. Then the next question was, what are the drivers of success as a country that was selected as an exemplary country? Looking at what are the key policies, the program, the intervention, and other actions that were taken both at the national and subnational level to drive some of the reduction that was presented by Professor Tupri. So the relevant areas that we looked at was the policy and program, the cost benefits, the quantitative analysis of coverage, trends, and equity, and then key informal interview with stakeholders. That was basically in Accra. And then we also did some decomposition analysis on the drivers of ASRHR, that is adolescent fertility rates. All right. So the next question was, what implementation methods were utilized by Ghana to enable them to enact relevant adolescent and sexual reproductive health? And then the key element we looked at was build on the analysis and discussions from the previous chapter. Okay, the views based on the summaries of the key findings as presented by Professor Otupri, where detailed analysis was previously done, and then what were some of the suspects, what drove those suspects in the secondary data analysis that was done, and then Ghana was selected. Next slide. Then we also had other questions. Besides the successes that we had, there were some challenges. And that is where we spoke directly to look at our policies, and then spoke directly to our adolescents. So what were the key challenges with adolescent and sexual reproductive health and rights for the country? What were the barriers to effective adolescent sexual fertility rate decreases? And those that I've highlighted in red were the major things that we focus on. Next slide. Then so we did a quantitative data analysis looking at a multi-level modeling where we used the logistic regression analysis to investigate at the individual level, at the household, the community, and the health system attributes that affect adolescent pregnancy. We also did a multivariate decomposition analysis. We are yet to do the structure equation modeling. We just focus on the decomposition analysis. Next slide, and I'll talk more details when we get to the Osaka model. So the key outcomes were the adolescent birth rates, the adolescent pregnancy loss, the adolescent-induced abortions, And then the intermediary outcome was met need for contraception among adolescents aged between 10 and 19. And then the percentage of births that were wanted, and then percentage of births that were not wanted by the adolescents. Next slide. So we did a qualitative analysis, and we did the key format, focus group discussion, and in-depth interviews. So for the focus group discussions, we spoke to the females. We grouped them 12 to 14 years, 15 to 17 years, 18 to 19 years. Males, adolescent within the bracket of 15 to 19. So we had females that were grouped in those various age groups, and then we spoke to females between 15 to 19 years. And then we did a key informal interviews. That was mainly in Accra, and we focused on policy makers, program officers, lead persons of NGOs that are of priority to this study. We also spoke to traditional rulers, okay? And then in-depth interviews where we spoke to pregnant or married adolescents, and then the extremely poor groups. Yeah, so in all, we had 66 focus group discussions, 18 key informal interviews, and then 13 in-depth interviews. The knowledge informal, we focus on, as I think I've already talked about it. Next slide. Yeah, I think we can skip this as well. Now, how did we stratify the country into the three zones? What we did was to get data from our DIMS2 database. We estimated the average pregnancy per region. Overall, as a country, the adolescent pregnancy rate is about 11.4. With Upper East region and some other Upper East region, and most of them around 14, and Upper region had the highest adolescent pregnancy rate. That's about 15.5. Next slide. Now, to the ecological zones, on average, for the year under review, that is 2016 to 2020, for the northern zone, the lowest average rate, adolescent pregnancy rate was 9.6, and then the maximum was 15.5. The middle zone, the lowest was 11.1, and then the highest was 14.5, and then that of the southern was 12.5, and then 14.9 on average. Yeah, next slide. So based on the adolescent pregnancy rate per year, we use that to then classify the zones. Next, based on average performer, and then above average performer, and then the low, and then low. Next slide, we'll see that. So we have lower performance, average performance, and then higher performance. And those are the regions, and that is how we group them. So field data collection, we had 26 data collectors, 26 field data collection teams, 23 enumerators, and 3 supervisors based on the ecological zones. So each zone had a 7-member team of enumerators with 1 supervisor. And then we had one of the 7 members as a note taker. Each pair was assigned a region performance category, that is below average, average performance, and then above average. Next slide. So these are the areas that we focus on, the stars where you are seeing for our data collection. Next slide. Now, for our secondary data analysis, we had the baseline, that is the Ghana Demographic Health Survey 2003 as the baseline, and then 2002 as the end line. And these are the numbers, the data, the sample size for each of the surveys that we picked our data. So we had data from the multiple indicator cluster survey 2006, the DHS 2008, again multiple indicator 2011, and then DHS 2014, multiple indicator 2017, 2018, and then our latest demographic survey. So this data set constitutes the secondary data that we use for the analysis. So you can see that is the baseline 2003 and the end line 2002. Next slide. So this database, based on the indicators that we wanted, it was, we analyzed, we look at the various questions of interest, and for some of the years we had, or some of the surveys, we had some of the questions, others we do not have. And those that do not have is what is highlighted in green, indicating that the question for that particular survey was not in there, was not asked. Next slide. So based on that, we had a complete list of explanatory variables of interest and those that were not there. So for this, should children be taught about condoms could not be found, and all those questions that we didn't have data is what is projected. The mean number of sexual partners in lifetime. We couldn't get some of those questions from the secondary data. So they were actually omitted from our analysis. Next slide. Then we performed the Osaka blinder analysis, which is a regression data analysis, which takes the mean between our baseline and our end line. That is 2003 and then 2022. So the main outcome of interest was the pregnancy in the 2 years prior to the survey, excluding women with more than 2 years prior to the survey. So our statistical approach, as I said, was the Osaka blinder decomposition, which tries to find the difference between the baseline and the end line. And attributes that were of interest was to estimate the coefficient. So the approach will estimate the coefficient multiplied by the mean change of the explanatory variable. So we have the outcome variable, and then we have the explanatory variable of interest. Next slide. So based on the analysis, we had these indicators in there, in our Osaka blinder analysis: the age, the marital status, the years of education, ever had intercourse or met need, and wealth quintile. Normally, wealth quintile is classified with 1 to 5, but it was regrouped as 0 and 1. And we had unmet need defined as when a woman or women with a need for consultation or a contraception, based on our definition for unmet need. Yeah, next slide. So that is actually what we did, and we were able to do this analysis that we've met here this afternoon to inform the public about this wonderful project. Thank you. So I'll now take some questions, if any.
Okay, Prof. From age 10 to 19, adolescent, why did you do the wealth quintile analysis? What informed your decision to do that?
Wealth quintile.
Yeah, I saw it on the
House, yes.
household
Wealth.
household wealth.
But
Yeah, so why did you do it? Age 10 to 19. Are they independent?
No, to know what problem might drive a youth, a adolescent to act based on her needs. So if you know the wealth of the household, they will be able to tell whether the adolescent will be able to have what she needs, and they maybe probably stay away from going to the meal for support. So it's actually based on the household wealth. Because they are not in school, so, or they are not working. Yeah.
Yeah, thank you very much for the presentation. I want to find out any reason why, the reason for which I think the KII
The traditional was actually spread. The traditional was across the zones, but most of the policy makers were in Accra. Yeah. So that is why, and most of the NGOs, they have their head offices in Accra, so it was easier talking to them, and then it can be extrapolated as a national policy. Yeah.
Thank you. Please, any other questions? Okay.
Hello. Yeah, thank you. Just a clarification. The study was done in all 16 regions, and they were classified. It's just the slide where you show the classification. If we could go there, I think there were 2 regions missing. I'm just wondering, Bono and Ahafo were not on the slide. Did you put them in the central, or I'm just wondering?
Bono
what
would
the-
have. Can we go
Please,
back?
can we go to the slide? There was Bono. No, not this one. The slide where you spoke about like the classification of the regions into. Momo, can I have the picture? There were 14. Back. The scope of study sites. Back. Well, let me just move to the question while we try and find it. It's just, would the classification of them change anything, or like that was in there but it was just an oversight? I just want to know, would it change any of the findings you had for if they had moved from maybe southern zone to middle zone? Yeah. Were they classified under middle zone or northern zone for Bono and Ahafo?
It wouldn't change.
It wouldn't change, okay.
Yeah, it wouldn't change because.
And then where did they fall? Did they fall under middle?
They would have fallen under the middle zone.
Okay, thank you.
Please, any other questions? Okay, if there are not any, then we'll move on to the next section.
Thank you.
Good afternoon. I'm Roberta by name, and I'm doing this with Shakira.
All right, so we'll have our third session, and we're going to have Mr. Ebenezer Dasa to elaborate more on the qualitative survey results of the ASHA project.
Good afternoon, everyone. As the moderator said, I'm Ebenezer Dasa with KNUST. I'm coming to present on the qualitative findings of the ASHA project. So I'm building upon what Prof. Nakwajes came and gave. He gave the approach we use. Now I'm coming to present on the qualitative aspect of the project. Next slide. So this basically the outline of my presentation. I'll give you the participant demographics, followed by the key themes we identified from the qualitative data, and then the summary of the key themes. And we have a couple of photos about the adolescents we conducted the interviews with. Next slide. So basically, we grouped the adolescents into 3 major age groups. And the previous presenters have indicated these age groups. So those within the 12 to 14 years, there were 21 people within the age range. And then 18 to 19, 23 participants. Then we also interviewed healthcare providers and focal persons in some of their regions. And then we interviewed 18 key informants. Next slide. So these are broadly the key themes we identified from our work, the qualitative aspect. So first, I'm going to take you through these key themes, and that will encompass my presentation. But key to these themes are contemporary issues or dynamics that influence adolescent access to sexual and reproductive health and rights. Next slide. So the first contemporary issue had to do with puberty right. Adolescent behaviors, they were shaped by complex issues that are both positive and negatives. And these include festivals and puberty rights. And those highlighted in green are the quotations we took from the adolescents during the interviews. So one positive aspect of it is that cultural rights and celebration, it makes them stay away from sexual activities. But there was a negative issue about these festivals and cultural rights. Example, one of the participants indicated that because of Bragro perform, it's a kind of right. Those within the Ghanaian context, you know Bragro. So the person feels she's now grown and can be with a guy. The adolescents, they like using certain keywords, modern terms, and some of them were emphasizing on this guy matter. I hope I'm right. This is what some of your colleagues, and maybe some of you participated in this project. Yeah, and there were also contemporary issues that shaped their access to what? Sexual reproductive health and rights. And some of these include Valentine's Day celebrations. Okay, that's one. Oh. It's okay. So an example is some two when it is Valentine's Day, they will go and meet the boy. I hope the adolescent with us, some of these things reflect what you were telling us, or our data collectors. There were also traditional rules that regulated adolescents' behaviors. And this is a long quote from one of the adolescents, that if you are a teenager and you get pregnant, your parents will give you give the community 10 bags of cement. So let's say your parents is not having money and you want to engage yourself into this, they won't get money, so it will reduce teenage pregnancy. So there were also issues around peers' influence. And that's the role of peers. Adolescents, you know that peers play a significant role in influencing your sexual reproductive health and rights. And these are some of the issues. So specifically, those within the age brackets of 12 to 14, they are likely to what? Emulate the sexual behaviors of their close friends. And an example is this. They have warned us about when we are following them, we can easily be influenced by peers. Yeah, next slide. Another theme relates to the contemporary Ghanaian family structure and how it influences adolescents' access to sexual reproductive health and rights. And these are the few issues around the family structure. One of the key issues is around economic dependency and parental influence. An example is the lack of parental care and economic instability or financial instability. Because of that, an adolescent indicated that her parents gave her to a boy because of money. The parents are poor, so they gave her out to the boy so that he can be giving them money for spending. I hope this resonates with some of you here. It doesn't resonate with you. Okay. So, and then another key family issue is, I think the previous presenters talked about it, the lack of open conversations around sexual reproductive health and rights. And then broken homes and rebellious behavior, and then influence over parental guidance. Next slide. Another key theme we identified from our data was around access to sexual and reproductive health services and rights. And they were influenced by three major factors. Socioeconomic issues, I talk about the financial issues around it, the cultural norms, and then one on the health care provider interaction. I think one of the adolescents emphasized how those kaya that when they go for services, sometimes they are denied those services. And then one key issue we also found from the data was around where do these adolescents get information about sexual reproductive health and rights. And again, one presenter indicated the role of the social media, TikTok. And some of you were denying you are not on TikTok. So mostly from the media, it can be the social media, but these two major sources, from your peers and social media, they have an overall influence on their sources of receiving information. Let's go. Then we also found that there are certain barriers that impede adolescent access to sexual and reproductive health services and rights. One of them is around stigma. Another issue we also found was around parental constraint, where cultural barriers and parental attitude make it challenging for adolescents to communicate openly about sexual health topics. And an example from one of the adolescents is that parents are sometimes too strict, making it difficult for us to discuss sexual health. I hope it's true. This is all about you. Okay. These are a few of your peers who gave us these nice quotations. Next slide. And they were contemporary people emphasize on rights, my rights, I know my rights. We also found that adolescents talk about legal and human rights concerns around sexual reproductive health. One of them said there's discrimination in service provision, and which raises an important legal and human rights concern. An example is, because she's a child and her parents are not aware, they said it's a family plan, so we should get in touch with her family before she does it. These are just a couple of quotations backing the issue around discrimination in service provision. Next slide. So they were also, these are mainly from the key informants interviews. So they identify certain drivers that seek to improve access to sexual reproductive health and rights. And one of them is around building partnership across sectors to address some of these issues. And I think some of the previous presenters emphasized on this point, on the need for multi-sectoral engagement and collaborations. So an example from one of the key informants is that we largely work with the Ghana Health Service Division, Family Planning Division, Adolescent Health Program to enhance the scope of our expertise and services on sexual and reproductive health rights for adolescents across our catchment zones. Next slide. Another key driver identified was that peer interaction could be leveraged for sexual and reproductive health education. And this is a quote from one of our key informants. Then they also talk about the need for digital and other innovative health interventions. And I think there's an app, what's the name again? The rep from Ghana Health Service talk about YMK. Yes. So these are all issues that are serving as drivers for the improvement of what? Access to sexual reproductive health and rights for adolescents. Then there was a team around access to quality services at both the national and local levels. So an example is, at our end, there's a building monitoring evaluation component, quarterly monitoring visits to the project site. These quality control measures improve the sexual and reproductive health services rendered to adolescents. Then another driver is that they emphasize the need for what? For funding models to reduce dependency on sexual relationships for financial support. And this is a quote back in that statement. So there were also findings around abortion, and participants talked different sources that they rely on. Some of them were herbal methods, some pharmaceutical procedures, some clinical procedures. And in fact, there's a code, I was wondering, the last code, you crash a glass bottle and mix it with Coca-Cola and use it for abortion. They were giving different kind of methods they use in abortion. Next slide. And then there were issues around access and cost. And then they were driven by what? Economic decisions. An example is that for the abortion, they don't cancel you, but if you want to have it and go to the hospital, they will do it for you. There are a lot of codes around this. It was an interesting area we explored. Next slide. Then there were also what would motivate adolescents to engage in abortion. So some of the sub-issues we identified was that economic dependence, social disgrace and peer pressure, and educational aspirations. Some wants to go back to school. So it motivates them to undergo abortion. And these are a few quotes supporting that. Next slide. And then one major issue was around inclusivity and equity. And that's around those marginalized groups. And I think Vera highlighted it, around people with disabilities. So our finding reveals that there weren't specific services that target marginalized groups like persons with disabilities. And this is a quote from one of the participants. Normally, when they are giving sex education, they only give to those in school, ignoring those with disability like us who are out of school. So this is an area some of the participants were emphasizing on, the lack of inclusivity and equity in accessing sexual reproductive health and rights. Another issue was that economic status of these marginalized populations impacted on their access to services. An example is this. When a disabled gets pregnant and sees there's no hope and she doesn't have work to do and no one will be able to give her money for maintenance, she resorts to committing illegal abortion. Then around inclusivity and equity as well, the findings also reveal the recognition, especially from our key informants. They recognize that the current access to adolescent sexual and reproductive health and rights, there's a gap, especially for those with disabilities and those in what? Remote areas. So in summary, I took you through the cultural dynamics that influence adolescent access to sexual and reproductive health and rights, and then peers as key influencers, and as well as social media. And then the family dynamics in modern times. There I took you through the economic driving factors that will motivate adolescents to engage in sex and all that. And then I also gave you about barriers and facilitators that can serve as the provision of sexual and reproductive health and rights. These are just pictures of the focus group our data collectors held with some of the adolescents. Thank you.
Mr. Ebenezer, thank you
and,
so much. Thank you, Mr. Ebenezer, for this presentation. Please, any question for him?
Oh, then it's well understood. That's fine.
Hello. Hello. I have a question. Yes, inclusivity, but I'm not too sure that the kind of work that the Ghana Health Service does around sexual and reproductive health is restricted to only individuals who are, in quote, normal, in quote, or able people. I am not sure again that if there's a health facility that provides these services and an individual with disability decides to accept service, that person will be denied. So this one, when Vera spoke about inclusivity and the fact that she didn't hear about access to individuals with disability, I got excited because I have a sister from the special education division who would have asked this question if she was present. So I said that, oh, if you have a kind of question, I maybe say. But I am not sure that, but the work that, where is he? Oh, the acting DG and her group does or do around reproductive health. So I wouldn't. Maybe you need to unpack. Tell us if there were some conversation behind what you have just done on the presented on the lack of services or access to services for individuals with disability. We want to learn so that when we get there, we'll be able to serve them better. Thank you very much.
Thank you. I think that's a great question. So, moving forward, with these participants, we didn't get those with disabilities, but there are others who had that experience from people with disability who talked to them about the challenges they face. And I think the acting DG might be in a good position to throw much about the policies around. Sorry for putting you on the spot.
Yes, I didn't hear the question. I was speaking to my former director, Dr. Kofi Issa, please, over there. So ask the question again. DG is here.
Former Director General and then the acting sitting Director General. So maybe I was just worried about the fact that the presentation revealed that there was lack of access to reproductive health education or services to individuals with disability. And I wanted to find out if, for now, the kind of service that we render, we say that this is for only people who are, in quotes, abled, and that we intentionally or deliberately deny individuals with disabilities a service to ASRHR services. Thank you very much. Because I'm not sure that that's what the Ghana Health Service does. So, and the presentation has some issues like that. That's what I want to know. That what is it? That
Okay, Vera wants to go first.
So yes, so if I may come in now, what I was trying to say, which has been buttressed by the presentation he made, is the fact that it might not necessarily be that you are discriminating against persons with disabilities, but you must be deliberate. Because by just thinking that they can also access the same service as you have for other people, it's also not right. They have special needs. You had said that your office people, those who working on special need, would have asked the same question. Because there are people with special need, you may have to do some arrangements to meet their specific needs. So it could even be that for that health facility that the person with disability must enter, even access, infrastructure-wise, can be a challenge. It is possible. In some communities, maybe, I mean, even here, as we are, there are adolescents, but none of them is having any form of disability. Imagine the person was in a wheelchair. How would the person have gotten into this room to partake in this important discussion? And so if you are not deliberate, it is possible that you might have your policies, but they will not be targeting those with special needs. And so that's what we are talking about here. So you see, even those without, we're talking for those with, because they live in the same communities with them and they know what they go through when they want those services. So it is one thing thinking that the policies are there and the issues are being addressed for everybody, but it's another targeting it to suit what they will need in order to benefit equally from the same services that you are providing. So that's what the presentation buttressed. And so that's why I also asked that earlier question, what interventions they are having in place in particular to help those with disability in their localities. Thank you.
Right. Kindly remind us that your presentation actually highlights the infrastructural access for people living with disabilities. Yes, because Vera is right. If health facilities are not accessible for people with physical disabilities, it may be difficult. And sitting here today, I cannot promise that today and tomorrow we are going to restructure the build of the facility. It will take a higher level member and a longer time and different conversations. I was telling MOH behind me that they should give us money. They should give us money. So that we can break some of the staircases and build, is it a ramp? Yes, and all of that.
It's even just one example. The person with hearing impairment goes to a nurse, how to even communicate so that she can really tell her story for the right service.
So we are,
it will be a challenge.
I mentioned sign language, and currently with the health promotion division, we have not even only the Braille, we have the Braille and sign language now, but we are developing modules on accessible communication to train the health worker to be able to communicate with, we are in the process. We've had about 2 work sessions, so it's happening. And this accessible communication is not only sign language or Braille. For instance, people that are colorblind, how are we going to show them print materials or materials online and all of that? So as for that, we are working on it now or currently. But what I cannot promise as at now is the built environment of health service provision sites or facilities.
Okay, thank you.
Can I?
Yeah.
Okay, so, but I'm sorry, but so we'll still need a certain going beyond the presentation and know what exactly were the issues with the people who responded to these surveys. Thank you.
Yeah, so with our participants, we couldn't find those with disabilities. And since the many people are here wearing the blue, whatever, okay. This one interesting area we can still unpack. Researching the sexual and reproductive needs of different types of disabilities, even those with intellectual and developmental disabilities. That's one key population that people tend to forget about when it comes to these issues. It goes beyond the physical infrastructure. to even include how to discuss all these things in a simple language to those with intellectual and developmental disabilities.
And so about 3 or 6 years ago, Edmond is here. We have a module on caring for adolescents with special needs, autistic children, those with developmental issues and all of that. And even when we are training service providers in safety nets, that's caring for the pregnant adolescent girl, we include some of these modules and into the larger AYFHS trainings. What happened was that there was a time a social worker reported that there was an autistic child who couldn't cater to her menstrual hygiene needs, and men were having sex with her and she got pregnant. And it's another thing I've experienced. I was in a clinic, an HIV clinic, where a woman had two twins, but she was not, okay, she had a special need. Let me just put it that way. She had these developmental issues. She couldn't even speak coherently, but men still found a way to impregnate her. And she was HIV positive. Yes. What did you say? What did you say? Thank God. Yeah, so these are some of the trainings we give to our service providers so that when such people come or when you attend to such people, you take extra caution and care to elicit some information from them and all of that. But it goes beyond even just the health provider and the adolescent. It goes to the family because there's a caretaker for this person. So we go beyond that. It may not be widespread or it may not be where the areas you conducted your study, but I'm sure some service providers would have had this training some years ago.
Kind of train them on how to handle some of these complexities.
We are rolling out a curriculum based for the ambassadors, and we've started with ASRHR. We haven't gone beyond that because it's a bit more technical. However, as part of their role, they refer to a parent facility or their supervisor who is the service provider. So if you encounter something that's beyond you, you refer. And their role is also to provide non-clinical services to young people, so counseling and all of that. We want to, phase it out in bits to see how they are able to do that.
No, I have a hand here.
Sorry, hello. While we are waiting, I just wanted to state, while she's working on the mic, state that when you're talking about a person with disability, it's always great to say a person with disability, a person with hearing impairment, a person with visual impairment. It's a nicer way to frame it. And then second, I think your presentation was mostly on the sexual aspects of ASRHR. Did you do anything on menstrual hygiene? I was just wondering along those lines. And then, sorry, because it's ASRHR. So I'm just wondering, was there anything along the menstrual hygiene aspect? And I think that's basically it. Sorry, is your mic now?
Thank you. There were so many teams. We just teased out what we thought. Yeah, there were some on it. And in our write-up, you get to know, yeah.
Hello. Okay.
Then the last person, because of time.
It's just a suggestion based on the conversation, the question our little friend asked in connection with the KIA, having access to nurses and stuff like that. So for domestic violence, the Ministry of Children have a model that they use, which is termed as the paralegals. I was suggesting that basically people are usually comfortable within their like confines. And so maybe we can adopt that paralegal system whereby we train some market women to serve as maybe a first stop for those who are in need of sexual and adolescent health issues, so that they can mitigate or advise them before they refer them to their nurses. I think that will help, because if you say that the nurses are not willing to maybe deal with them, or it might not even be the case that the nurses are not willing to deal with them, but it might also be the case that because of that barrier, people are not willing to even go to the nurses because of one thing or the other. So maybe we can look at the paralegal system that the Ministry of Gender is using in terms of domestic violence, and then probably adopt it to suit our current needs. Thank you.
And here. All right. Good. I want to go still. When I look at the factors that you identify that delimit the adolescent from accessing the services, even to the extent of her, i.e. in terms of KIE accessing and whether the nurses are friendly or otherwise. Let's widen the scope in terms of looking at what actually are the real factors. Because if you take for KIE, depends on where they are coming from and here. Depends on who the nurse is and giving that service. And the value that they place on it. How they see the KIE will not even allow them to interact. How they see the KIE will not allow the KIE to go closer to them because of how either they receive them or otherwise. So I'll go with her to say that, okay, let's devise another plan where we can have people who can be like a bridge between day and then day services. Now, I see that you identify cultural factors. I see cultural there. To the extent that you yourself, in the work, we didn't talk about the disabled people that we're talking about now. How did we see it in the first place that in the design, we never saw it? It's also coming from culture. Maybe it's a blind spot that we haven't been seen at all. But these people need the service. So we need to look at it very well. There are other more factors, especially now our society is more open and allowing more other people to come in more. I take the very vulnerable Fulani people. Are they not here? If they are in the community, are they not here? Are they getting the service? How are we reaching out to them? Ghana is not like in other communities. It's a very open community. So a lot of people come and they access all those ones. So let's look at all those factors. What do we think about children? What do we think about the adolescent? How do we think about other tribes? How do we think about other characters that make people not getting so that we can maybe reach out a little. Thanks so much.
Okay, so we have one last question from an adolescent, one of the young people.
Yes, my question is for Madam Sharifa, if I got your name right. Yes, you mentioned some amazing training sessions that health workers in Ghana have undergone to be able to provide better services for persons with disability. And I want to find out what monitoring and evaluation mechanisms or structures are in place to ensure that the trainings translate into actual service delivery, and what kind of challenges are the health workers facing, because at the top, I know a lot of money being invested into the training to ensure that there's better service delivery. I just want to know if there are any M&E mechanisms there. If they are, how are they operating? Thank you.
In the ideal situation, or in an ideal situation, we used to have quarterly monitoring. The money pumped at the top, there's no longer that money. But yeah, we have an M&E plan, and we visit service providers to actually observe some of the sessions and, ask some routine questions and support them in service provision as regards young people living with disabilities. However, the big challenge is staff attrition. You train a cohort of adolescent health service providers, and the next time you are there, the person leaves without giving an on-the-job training to his or her colleagues. So that's something we've been battling with currently, and apart from funding, that's the major challenge to maintaining or retaining service providers to provide these services throughout their stay in the hospital or facilities.
Can I quickly say something, please? So just to piggyback on what she said, since GES is here, I'd like to take the opportunity to put this out there that I think it's time we started including sign language, like learning sign language, like ASL and all those things in our basic education, because it's a form of inclusivity. And there's also the need to realize that people living with disabilities are going to be with us. They shouldn't be secluded and then they only go and learn their own ways of communication. We should all learn it together. That's how you can include them. And that's the only way that I would always be mindful, because now I can speak, I can communicate with you regardless of the disability you are living with. So that's an opportunity, since GES is here, for us to take up the mantle. And also, I think we should widen our scope to not just nurses. Nurses are very important, especially in the hard-to-reach areas, in the CHIPS compound. We also have TBAs. There are some regions and areas you will not find a nurse. You find a TBA. So they should also be included in our focus areas. There are places you find OTCMS, over-the-counter medicals, like medicine sellers. You will not find a nurse. So let's broaden our scope when it comes to the education and not focus on just nurses. Let's look at the midwives, let's look at the TBS, let's look at OTCMS, let's look at pharmacies and how we can make all these areas very, very adolescent friendly. Thank you.
Please, with respect to family planning, is the government doing anything to reduce the cost for adolescents? Yes, please.
What was the question?
Family planning, what's the government? Please, with respect to family planning, is the government doing anything to reduce the cost for adolescents?
Yes, the government and UNICEF are actually doing something to reduce the cost of condoms. We have a family planning program that's for the general family planning commodities, but the Adolescent Health and UNICEF, we are actually implementing a study that seeks to reduce the cost for condoms so that young men like you will not go and say you can't eat toffee with the wrapper or you don't eat banana with the pills. You must eat it. Sometimes eating with the pills is nice, and we have subsidized prices, but it's still in the project site. It's not countrywide. When we get the results, we would scale up. Okay.
Hello. I just want to add to Sheriff's response. The NHIS, the NHIS currently covers family planning. So if you have a card and you get into a government facility, you should be covered. I know currently the NHIA, working together with NHIS, are trying to kind of register some more adolescents. So
okay.
So there are efforts in that direction.
So your card must be valid.
Yes.
Yes.
During the presentation, I saw something about parents are too strict and won't allow their wards to learn about their sexual health. So I wanted to ask that, like, what is the solution to that problem? Yes, please.
Parents, you said during the presentation, so I thought you were talking to him.
Talk about the Happy Family game.
No, I didn't hear what she said.
No, it's about like parents being strict
Yeah, I wrote
and don't want to talk about sexual reproductive health to adolescents. So she's asking whether we can get solutions to that issue.
We have a solution brewing. It's already in the pot. So actually, when he mentioned that in his presentation, I wrote it down, that we also set out to understand why young people are not accessing adolescent and youth-friendly services, in quotes, SRH services. And it came out that they are unable to speak cordially with their parents. So we designed a game. Yeah, let me just say a game. We call it the Parents-Child Communication Game or Family Board Game. And it encouraged adolescents and their parents, mostly it's mothers. Fathers didn't have time to play with their words, yes. So, yeah. Okay, you are objecting. Is Siobhan here? Siobhan, am I right? Is Sonia here? Sonia, am I right? Yes, I was on the field with them, and the men were not playing the game with... No, we went to all the sides. We went to 2 districts in Ashanti. Yeah, but basically, that's it. So the game has been able to improve communication between parents and their wards. We are currently monitoring 3,000 participants on this game. And so when you mentioned that, I was hoping that maybe in my final comments, we would discuss if you need to help scale that in the areas that parents and their wards were not communicating. And we actually watched some of them play the game. But the downside was that it's written in English. So most communities, because of their ingenuity, decided to use other games, maybe Oware, Ludo, and all of that, because they couldn't read or understand some of the instructions. But currently it's working in Adansi South and Asante Akim South. So that's what we are doing. Yeah.
Can I add a little to that? I think apart from that, we need to move away from just the games alone. I mean, can we, create, because in Ghana, we don't have any structure, any organized structure or system that helps to tell people what marriage is and how to organize marriage, what parents discuss with their children and things like that. One of the things that we can do that is likely to work is that we know that this is a very religious nation. I mean, we have a lot of Christians, we have a lot of Muslims and other religions. Can they actually make it part of the curriculum that they use in the so-called premarital screening for them to know that these are issues that you need to discuss with your parents? And then also, can we encourage some of these religious bodies to discuss it in the church premises, how to manage it? The thing is that I do have children. I have a girl and 2 boys. It's a difficult thing. You must know how to introduce it. You must be taught. Then there's no way that people, because marriage is something that nobody is taught. You just go in there and then you are supposed to practice it and all that. So can we have a way of helping these parents? I mean, if you have a book or if you have a guide that we can share with parents, I think it will work. Thank you.
So that's a really good question and really relevant and valid. And at UNICEF, child protection section in SBC and other health sector and other sectors are working on developing a parenting program for parents of adolescents so that they have a resource, or we're not sure what it's going to look like yet because it's still in the preliminary stages. And we're going to try to co-design this with parents themselves so that it will resonate better with them and in a modality that they're comfortable with. But yes, this is definitely something that we've been thinking a lot about and that we think it's important to address with our government counterparts, of course, in the lead.
Just to
And
add
I
to
think
that,
the game came about by, we conducted a formative study and we distilled insights in the districts. Then there was a co-creation workshop where service providers, parents, community leaders, and adolescents actually shifted their focus on a game. So we just had to go with that because they thought if we did that, there would be some positive results, and we are having some positive effects with that. So we didn't just, pick that out of many options we could have thought of, but this is actually generated by evidence from the study districts. Yeah.
So just to add to that, it's not just about what we are doing for our parents, but also to you adolescents, grow up to be the parents you want to see. So for sustainability's sake, as you are listening, you say that it's difficult for you to communicate with your parents. Don't become parents that it's also difficult for your children to communicate with you. So as you are here also giving your concerns, we are hoping that you are learning from this and you are becoming young adults. You will become young adults and possibly parents that your children as adolescents can speak to. Thank you.
Please, I want to ask our elders here that what are the government doing to prevent stigmatization of adolescents?
Doing to prevent stigmatization
of adolescents?
Services.
Yeah.
So government with partners. All of the partners I mentioned. What we are doing is that we train our service providers, because CSOs also have their service providers, NGOs, governments, health service providers, right? We train them to be adolescent and youth friendly and to provide adolescent and youth friendly health services. We have safe spaces for the government side in the name of the corners and community, whatever. I think NYA has the something resource center and all of that, so that we can bring services to people that, some adolescents also self-stigmatize themselves. They are afraid that if they come to the hospital or if they visit the service provider, it's a perception, she might say something, so they don't go. So it's not always the case that it's the service provider that is not good. Yes, some of them are. Have you experienced any service provider like that? Like you people here? Have you? It's hearsay, right? Yes. So I'm not defending service providers that
Didn't come as a stigma though. However, the service provider was a male and there was no female at the time. So I think he wanted to take advantage of me, and I was really quick, and then okay, so by then I was already empowered, so I could say no or yes, if I agree or not, and definitely I said no, so I didn't agree to the service, and then I had to wait for a female to come during her shift before I was attended to.
Yes. Okay.
Yes, I had severe cramps, so he had to check and all that, and I felt as though he would take advantage of me because of how he approached. So I had to wait for a female personnel to come during her shift before I was attended to. So it's in a different way, but...
Yes. So as part of adolescent service provider communication or interaction, we even train them that if a female comes and he's a male service provider, you should have a chaperone, a female standing in. And if you, the young person, is not comfortable with having a male service provider touching you, you say it as you've done. So that was laudable. And as I said, I'm not holding brief for all service providers that they are good. However, we have so many other people supporting us and training service providers to be youth or adolescent friendly in their provision of services. We will get there. So we are sorry to hear what you said about the male staff. You thought the male staff would have touched you beyond what you went for. We are sorry to hear that.
Thank you. Please, we are moving to the next section.
Hello, there's a contribution from GES.
Okay, so I want to say that child protection has a code that when you feel or you know that you are going to be abused or you think like you will be abused, depending on what the approach is. You can report, you can call the code and report the issue. Because I'm also thinking that if there is a mechanism like that in place, people will be careful in handling the adolescents. So it's important that you know of this code and report issues of abuse. Thank you. Yes, we are checking it. We'll just give it out to you.
Good afternoon once again. I go by the name Enam Ajolo, and I'm your co-moderator for this section. Over to you.
Okay, so we are in our fourth section, and we are going to have Professor Ismon again on board to throw more light on the quantitative survey results of the ASHA project. Prof.
Thank you very much. We are getting tired, but we just have a little more to go and then we'll go for lunch. The issue about adolescents is special now. There's no question about it. We have the largest population ever, largest numbers ever. And we also recognize that there's the triple dividend of adolescent health that we can benefit from, in addition to the demographic dividend. So the issue about adolescents is no longer play game. It's serious business. And that is why we are putting in all the efforts to direct our attention to these adolescents so that we can reap the benefits of these two dividends. I will go ahead and walk us through, have this little discussion and look at these three types of quantitative analysis that we're undertaking. This time, it will be more on Ghana data. So we will do a few comparisons, yes, but mainly we'll be talking about Ghana. Currently, based on the census, the 2021 census that we had, we have about 7 million adolescents. And that's about the population of Western region. So we have that many, and they represent about a fifth of Ghana's population. So every fifth person is an adolescent. But then there's the discrepancy between urban and rural as usual. Now, Ghana is more an urbanized country if you use the definition for an urban area that the Statistical Service uses. We are more the population is higher in the urban area than in the rural area. So I think it's now 52-48 thereabout. But if you look at, in terms of 10 to 19, the adolescents, in urban Ghana, about 21% of the males are aged 10 to 19. But then about 24% of the females are aged 10 to 19. The females have moved, and they've left us behind in the rural area. That's a difference, a demographic difference that we need to consider when we are offering services. So we'll skip these and go next slide. Sorry, I thought I was controlling. Forgive me. So I was wondering, next slide, please. So we've seen all these before. Next slide. Next slide. Yeah, so these are the variables or the characteristics that we looked at. And we were told about these during the methodology session. Next slide. Next slide. Let's begin with the types of analysis. We'll begin with stay there, go back. The benefit cost analysis. Others call it the cost benefit analysis. I prefer this term because it helps me to remember what is the numerator and what is the denominator. So the numerator is the benefit of the intervention, and the denominator is the cost that goes into it. And usually you come up with a ratio that determines whether it is worth the amount of money that you're putting into it. So if the ratio is higher than 15, then it's excellent. If it is 4 to 14, then it's good. If it is 1 to 4, fair. Under 1, poor. So based on that, keep that in mind to help us make judgments about interventions. Next slide, please. So we looked at interventions that reduced unintended pregnancies among adolescents mainly. And then we selected the cost-efficient interventions that reduce these. Next slide. Now, based on literature, these are the areas, the 4 areas, and then the components that list interventions that lead to reductions in pregnancy among adolescents. So these are the areas that will appear mainly in the analysis. Next, please. Next. Now, I skipped that because your laptop is not showing us correctly. We're supposed to go back one step. Yeah, okay, so these are for all the countries that participated. But for Ghana specific, next slide. On my laptop, there's supposed to be a separation between these two. So you can see what I want to demonstrate. Now, what was done was that, okay, let me try to explain. What was done was that, first of all, we looked at the baseline of the interventions and their costs. And based on their baseline, we determined that for Ghana, it looks like the integrated health services, the peer-to-peer learning, and the youth-friendly services, as in integrated services, health services, were the interventions that were good for us. Now, when you do that, you also increase the cost by 20% and then decrease the cost by 20% to see whether it stays the same. So, Great. This is what I was looking for. Thank you. So, if you look at the green, let's say orange, states the baseline. So as far as the baseline is concerned, of the factors, interventions that we are looking at, it appears that the integrated health services gives us the best ratio, in addition to the peer-to-peer. So the integrated services gives us 23 as a ratio, right? And followed by the peer-to-peer, and then the youth-friendly services, and then girls' education. Now, if we increase the cost by 20%, the picture remains about the same. In other words, the integrated services lead, followed by peer-to-peer, and then we have the youth-friendly and that. And if we reduce the cost, the picture also remains about the same. So these are the to-go interventions for us in Ghana. Integrated health services, peer-to-peer, and then youth-friendly. Next slide, please. And here we list them. So at baseline, integrated 1, peer-to-peer 2, youth-friendly 3. They remain the same at a 20% cost increase. Next slide. So the takeaway from the BCA analysis is that the beneficial interventions include the ones I have mentioned, and then formal education. Continue. Next. Let's now move on to the regression analysis, and there's a lot to look at here. The outcome indicator, the primary outcome indicator is this: adolescent pregnancy. Next. And these are the intermediate variables that were looked at. And we'll look at modern contraceptive use. We will skip that, and we'll skip that, but we'll look at gender-based violence as part of the rights issues. Next, please. So the exposure variables are the survey year, age group, marital status. And then geographically, we looked at urban, rural, and then region of residence, and then the geographic zone of residence. And then socioeconomically, we use the wealth quintile. And as I said before, all the data are coming from the DHS and mix. Next, please. So let's start with a teenage pregnancy based on the 15 to 19-year-olds. I checked on one of the reasons why we didn't have this before. It was due to the Rwanda, the lack of data from Rwanda. And that is why we moved to the higher age bracket. But now you will have it for Ghana. Ghana, we have all the data that we require. Next slide, please. So the pregnancy has remained about the same since 1999. From our DHS 1999 to 2022, it's just hovered around 15, and currently maybe it's about 13%. But 13, 15, 2 percentage point difference, no big deal. Next, please. Now, we separate that by age group. So if you look at this, it tells us that the 15 to 17, they are less likely, right? But the older adolescents are more likely to get pregnant. Next. By residence. So we find that the rural, even though it has reduced, they are still worse off than the urban. Next. By wealth. So wealth, we realize that there's a decreasing trend of the proportion of adolescent pregnancy in poor households from 1999 to 2014. Yes, so that the poorest household is the lowest, right? And is decreasing. But then there was an increase in 2022 in the poorest household. But the richest household, the highest quintile, look at where they belong. They have the lowest proportions all over the years. The richer you are, the less likely it is. Next. Education, a big driver. So if we look at it, we find that those with no education or just preschool completed, they are the highest, right? They've been leading the pack all over the years, and even in 2022, they went even higher. Next, please. Religion, I don't bother about it. Next. Religion doesn't talk true. So by region, we realize that Ashanti region had the highest in 2022 according to the DHS. But the changes have been up and down, with Greater Accra region probably the best performer in terms of regions. Next, please. Next, please. So when we look at the data in terms of figures, and we perform a pooled multivariate logistic regression for Ghana using ever pregnant as the outcome variable, we find that if we use Greater Accra as a reference region, the difference by region is not statistically significant. So by regions, you don't have a big difference or statistically different. But when you come to wealth, we find that if we use the highest wealth quintile as reference, the differences are statistically significant. Next slide, please. Education, same striking differences. So if you use the secondary school or higher as reference, the lower levels of education are more likely to get pregnant, and the differences are statistically significant. Religion, skip it. Next, please. So if we then go ahead to do a pooled analysis of sexual debut, we find that if you look at urban, rural, the difference between them is about 10 percentage points. So 56%, or about half, of rural adolescents exited adolescence without a sexual debut, without ever having sex. But the difference between the residents is statistically significant. So compared to urban, even though the urban were less likely, that difference that we see here is significant statistically. Next. Same thing, and I'm going to report more on the statistical significance in most of the slides. When we look at, wealth, right, it's the same thing. The difference between the poorer households and the richer households is statistically significant. So wealth does have something to say. Next, please. Now, let us look at education. No education, primary school, secondary school. The differences, statistically significant. If you go to a secondary school or higher, the odds are that you will not get pregnant, or you have a lower odds of getting pregnant compared with no education. Next, please.
let's now look at pregnancy. So we're looking at sexual debut. Now we are looking at pregnancy. And the story is the same. Between the rural and the urban, the difference is significant statistically. Next, please. Same for wealth. No, between the wealthiest and the poorest, the difference is statistically significant. Next. Same for education. In terms of pregnancy, the difference between no education and higher education or secondary school level is significant. Continue. Let's now look at modern contraceptive use among married or unmarried, because we know that this is protective against pregnancy. Next. So when we look at the use across the years, we find that it was highest in 2022, 38%. And that for me made me very happy. Compared to the other years, which were quite low, the difference between even 2014 and 2022 is quite big. Let us see what it means in terms of statistical significance. Next, please. So, if you look at it by year, we find that the previous years, they were less likely. The odds were lower of using contraceptive use. But the difference was also significant, statistically significant. But by age, the two groups, no. By marital status, notice that those that were never in union as reference and those currently or formerly in union were less likely to be using or to have used contraceptives. By residence, the difference was not significant statistically. Next, please. By region, no difference when you compare with Greater Accra. We use Greater Accra as a reference because it has the lowest fertility rate for the adolescents. Wealth, no difference. Next. Religion skip, but education still. Even though primary school, no education, less likely, not statistically significant. Next. Violence. And here, the data is just for 2022 because that is the only survey that reported it in detail and used any type of violence. The others, sexual violence, but we're talking about any type of violence. Next. So the violence is, wow. The total number that experienced out of the total sample surveyed was 263. And that is about 9%. All right? And we find that across age group, it's similar. But when we look at marital status, we find that the never in union, slightly less, almost the same, but urban, rural, almost the same. Let us continue to look at the characteristics, the survey characteristics, and see whether they differ. Next slide, please. By region, we notice that Upper East and Eastern have a higher proportion, while there's a lower proportion or percentage reported in the Ashanti region. By wealth, similar. Next. By education, it appears the more school you go to, the more likely it is that it appears. Well, we didn't go into statistical significance with this, but we find that there's a higher proportion compared with those with no education. And probably this is the only variable in which the no school were better off. Next. So summary takeaways from the multivariate logistic regression is that the pregnancy rate is about 15 and is higher in older adolescents. Formal education, residence, household wealth are significant predictors. The higher education level and wealth and urban residents are protective. And there's higher violence in Upper East and Eastern regions. Next, please. Let us now look at the decomposition analysis, the Oaxaca blinder decomposition analysis. This methodology was first used in industry, and it shows the difference between two groups and decomposes the difference into the factors that explain it, the explanatory factors, and the factors that don't. Now, the first time it was used in wage, to look at the wage difference between men and women in industry. And now we can use it for health. Next, please. Next. So Ghana, as I said, we have data. I mean, our data spans across the study period, and we have access to all those data sets. And the baseline will be 2003, and the end line 2022. So we shall be comparing these two groups at all times. Next, please. These are the indicators that are not available across the survey years. In other words, some of them were not asked at all. Some were asked in part. And so we shall use those that were not available. We omitted them from the analysis. But then we're able to use another type of analysis to take care of those indicators or variables. Next, please. So let's now look at the descriptive statistics. Next, please. So Ghana has a lower pregnancy rate than Malawi and Cameroon. And this is Ghana for you, green there, right? And we are reporting proportion of 15-19 with any pregnancy or birth during that time. Next, please. Ghana has a distinct profile when you compare with the other countries in the sample. So adolescent marriage rate has declined over time in Ghana. And let us go graph by graph. I'm not sure whether you can see the details in the figures, but these are the ratios. That's all. Now, let us look at marital status. And Ghana is colored bright green. Okay, so marriage has reduced with time for the adolescents. Has had intercourse. It has stayed the same, right? Age at first sex has gone down. Unmet need, very important, has gone down. And we encourage the health service providers to push it further down, because that is one way. Use of contraception is one way that we can make sure that they don't get pregnant, meeting their unmet need. And we encourage GES, Ghana Education Service, to think about it again. Years of education. Notice that Ghana, it has gone up at least 1.5 years on the average, and we are beaten only by Nepal. Wealth. Notice that the proportion in wealth quintile 1, that would be the poorest, has gone down. So gradually we've pushed ourselves into the higher wealth quintiles, just like for all the other countries. But it's important for us in Ghana. So the share of women with unmet need declined from 2003 to 2022. Adolescents attaining more education increased when you compare 2022 with 2003. And of course, as I said before, the standard of living has also changed sharply. Next, please. Now, when you compare unmarried versus married adolescents in Ghana, they are the other countries, but let us look at ours. So the ever married are the blues, not Chelsea, but the blues. And then the never married is the khaki or brown color. And you can see the differences between the ever married and married in terms of these variables. Next, please. We can also look at, or we also looked at the modern contraceptive prevalence among married women in Ghana. And we are referring to the 15 to 19. So as far as usual, known, we find that there's always an increase, except for the ever married, right? But in all the graphs, you find that the ever married are much higher. So use, the ever married use more. Traditional method use, the ever married use more. Long acting, the ever married use more. And short acting, ever married use more. Not using any method, the ever married, they are less likely. And it makes sense. I mean, once you get married, then these things come into play. The what do you call it? The stigma attached to approaching Sharia and help people reduce it because you're married now, you got a license. So it makes it easier to go to Sharia's people. Now, there has been a substantial increase. We've mentioned this before. Go, next slide, please. So, having done the descriptive, let us now look more at the regression analysis. And as I said, it helps us, the Oaxaca blinder helps us to determine which explanatory factors have the largest impact on the declines, and a few others that we shall look at. For the rest or the variables that did not subject themselves to this kind of analysis, we use the sensitivity analysis for this age group pooled. Next. So the reasons why we exclude some factors is that depending on when the survey was conducted, the responses will change. So if, for example, you are attending school, you are 15, you are attending school, and then you get married, things change immediately. Contraceptive use, access to services, they all change. So if we come and ask you if we ask you the questions, go back please. If we ask you the questions at this time, when you're almost 20, the story is different. But for Rwanda, all right, let me explain the Ghanaian context first. So, for example, somebody who is 20 years has a kid. So you ask her, do you have a kid? She says, yes, I have a kid. And then you ask her, how old is the kid? So the kid is, let's say, 6 years. It means she had the kid when she was 14, right? But at 14, when you asked her the survey question whether she had a kid, she says no. So that is how come some of these variables are difficult to include in the Oaxaca blinder, but then we'll use the survival analysis to cover them. Next, please. Next, please. Next, please. Now, so from the analysis, Oaxaca blinder analysis, we can see clearly that years of education, right? Reduction in unmet need, and reduction in marriage, adolescent marriage. They are the key drivers. They are important for the changes in the pregnancy rates that we see. Next. Here, we provide only the statistically significant associations that try to explain the two directions that we earlier on presented to you. So for the variable explained, this is the explanation. So unmet need is explained by that much. Years of education is explained by that much. And then the marital status issue is explained by that much. The rest of it is unexplained. Next. So the mismatch that we talked about as a result of the timing of the event and the response, we use the cohort survival analysis to cover this. Let's look at that. Next, please. Go. So we are using data, as I said, from the DHS. And this time, we are using 2008, 14, and then the 2023. And this is the total number of women who were included in the calendar. And let's go to the next slide. We see that even with that, clearly, marital status, sexual activity, contraceptive use, and educational attainment are the key drivers. Look at them over here. So modern contraception use, right? Secondary, attending school, right? They are the big drivers. Next. We needed to look into this contraceptive use better. And we looked at it, and we can present or we can show that the modern long-acting, the use of modern long-acting has the greatest influence as far as the contraceptives are concerned in reducing the fertility rate among adolescents or pregnancy rates among adolescents. Next. So the takeaways. 1, pregnancy rate has declined in Ghana, but not that much because we keep going up and down, hovering about the same rate. Sexual activity was stable, but there's a decrease at age. There's a decrease in age at first sex and marriage. There are gains in modern contraception for both partnered and unpartnered adolescents. And women in Ghana have made major gains in education that has reflected in the pregnancy rates. From the quantitative analysis, sexual activity, marital status as in delaying marriage, and education, they stand out as key drivers. When we looked at the contraception picture better, we can tell that the long-acting contraception in particular does a great job. And completing secondary school education is very, very, very important in getting adolescents out of trouble. Next, please. Summarily, the tentative summary takeaways, survey takeaways. Education, underlined. Delaying marriage and sexual activity, and contraceptive use, they stand out as key drivers. We need to look at the residence and wealth issues too. And the school-based and e-interventions offer a great opportunity to improve these indicators among in-school adolescents with the expected contamination effect on out of schools. We explain this way. You know, when we looked at the BCA, the peer influence was there. And I remember that when I was in school, when I was in high school, I was in Accra, but my home was in Kofredua. And whenever we went home on holidays, those who were the local boys, they would come around, those of us from Accra and Cape Coast. They want to listen to what is happening in the bigger cities. So peer influence is a big issue. And if we can get our in-school to have the right information, instead of listening to what GES says, then we can be sure that even those out of school will benefit from their peers in school. Because we tend to think that those in school, they know better than those of us who are not in school. And I have to admit, though, that the policy climate in Ghana is very supportive, except for this little issue about GES and GHS. Now, if you take out the H and the E, you still have GS. So I don't see why we can't quickly sort that thing. We can't quickly sort that thing out, because the SHEP program provides a great opportunity that we are missing. We can use that in an integrated approach to cover even youth mental health for young people. We can do that through SHEP. So let us look at it and work with the adolescent to co-create interventions that they want, interventions that are targeting them, that are responsive to their needs, that answer their questions, created by them. And we shall get them to use it. If you don't do it with us, how do you expect us to sign up? Thank you very much. Now, having gone through that, let us now take a look at what we don't want, right? So, of course, we are thankful to all these people for helping us through. Next slide.
Maya. You didn't help us.
Hold it. Now, this is what we don't want. This is the type of adolescent sexual and reproductive health and rights. Remember that the adolescents have a right to have sex, like you. You're an adult, but they also have rights. Go on, let's see what happens here.
Maya. Jesus Christ of Nazareth. Kadzongwa mukabonga manje. Ukwaona kame wako.
Questions if you have any.
Please, thank you for the presentation. Please, do you have any questions or comments? Please.
Thank you very much. I don't have a question, actually. I think it's a very excellent presentation. I was literally jumping up and down in my chair as I was watching the slides flow because working on something, not the same thing, but then seeing like the data transformed there and then trying to make meaning out of it is very, very important to all of us. However, I just wanted to share from the previous session that we had, the number for the helpline. UNFP actually has a helpline for that you can call. It's toll free in case you're in trouble. I'm sure maybe child protection can give this, but we can give ours like out just in case. It's toll free means that you don't pay for it. Yeah. No, the lady said she felt that the health worker was going to. So we are talking about, yeah, we're not talking about armed robbery. No, please, no, not for armed robbery. Very great. So for sexual and reproductive, in that aspect, any gender-based violence, any form of abuse, etc., you can actually call that toll-free line. So it is 0800 111 222. So 0800 111 222. It's toll-free. You don't pay for that. Thank you. And thank you so much for the presentation.
Hello? Yeah, GES. Not GES helpline. It's also gender, Ministry of Gender helpline. Yeah. So 0800 800 800. 0800 800 800. Then we also have an SMS short code.
Do you want to do it?
8020. 8020. Then DOPSU. DOPSU also has a helpline. Oh, there we. That is 055 100 0900. Thank you. So the SMS is for all mobile networks. Thank you.
Okay, I think apart from the YMK2, there's something we left out. UNICEF's AGU platform, 5100. It's on MTN, right? Yeah, MTN, 5100. If you call via MTN, it's free. 5100. A toll-free number. UNICEF has a platform to support young people. It's called AGU. Yes. No. Still on SRH, calling for support, virtual support, and if possible, referrals. I'll let UNICEF handle that.
So, has anyone heard of AGU? Any of you? AGOO. AGO. Has anyone heard of AGO? It means we're not doing a very good job at promoting it, so that's very good feedback. So AGU is a platform for young people. You can call in to access information on around different subjects related to sanitation, hygiene, adolescent sexual and reproductive health, child protection issues. We had a COVID platform a while back when COVID was a bigger issue. So it's very relevant to whatever issue we're facing at the moment, but there's also information and gamification, so you can play games and things like that. So it presents the information in an entertaining way. So please, and there's an option to get referred to services if there is a need for that as well, to speak to someone. Charity, go ahead.
Yeah. Charity can do that for us.
Okay. Prof, so just to provide some information for the lady who spoke about the inclusivity and then the sign language from the GS side. So, and the GS wants to report that in 2016, the GS launched the inclusive education policy.
You can put the mic just right. Sorry.
If you are between 30 and 34 years, press 5. If you are between 35 and 39 years,
So it's collecting your data before
if
you
you
go
are
to the
above
messages.
40 years, press 7.
Yeah. But you see, there's a back end that collects these data so that we can analyze it.
But, Prof, apart from the, sorry.
One within, if you are within a particular year group. So to follow up on what Prof asked, first timer, I don't want to provide that. What do I do? That's the question I'm asking.
It's difficult.
Yes. Can I make a comment on that?
Okay.
A comment on that. Prof, the essence of it is not just to collect your data, but to be able to provide you the information that you need. And so your age group, there are a specific group of people who can provide that age group, I mean, depending on your age group or your category. So we want to know whether you are between the, you are an adult, whether you are an adult, you are a youth, you are what, adolescent, you are a young person. When we have that information, because I mean UNFPA, we also have the same thing. The response is similar to that. It helps us just to know who to direct your information to, who can help you and give you the right information. So apart from the data, it directs you to the right skilled person that can provide the information that you need. Thank you.
So, Doc, the other thing is that what I was saying is every month or every day, you can go to the back end and see how many times a particular, so we are collecting how many times one ID has called and on what subjects did they talk about or listen to. Okay, so that's why we take all this background information. And then also, when there's an issue, like an outbreak, we use the AGO platform when we had cholera in 2016 in the central region. And we realized that more people were coming from the university. So the university district or municipal, that's where the messages on cholera was pushed to, so that they'll have it on their phone, and then after some time, the outbreak came down. So it also helps us to, it's not only for them to listen, but also when we have an outbreak, we can also push messages through the same medium. You go.
Can't we have adolescents, just the wide range, 10 to 19? Mm-hmm. Can't we have one option like that?
That's why there are age groups on it, and there are life counselors behind this.
I know, but if we had an option for bad boys like Eben over there, he would choose. He doesn't want to be identified in any way.
He will not be identified, though.
Hey.
We are giving just a code. We don't even know who we are talking to. We only know
you are asking
male.
for the region I'm in.
Yes.
Hey. 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 Eh? What if you track me tomorrow and you come and tell my mom that, hey, this son of yours? Anyway, please continue. Sorry.
Any other question, please? Okay.
Responding to the inclusivity and then the Braille thing. Yeah, so the GS has a policy since 2016 on inclusive education because we believe that we all go to the same community. The community that we find ourselves is not demarcated into a community for exceptional individuals and a community for regular individuals. So, and we are also saying that we want, as much as possible, we want to educate everybody in the least restrictive environment where the environment that are very, very close to normal. You understand? Yeah, that's why we have the inclusive education policy. And then now it's become mandated that all schools have ramps and accessible spaces for everybody. Okay? And then the issue of the sign language, the Special Education Division has successfully developed a Ghana-specific sign language dictionary. Yes, and so if you come to the Special Education Division of the Ministry of Ghana Education Service, we will give you a copy of the Ghana, not the American Sign Language or British Sign Language, but a Ghanaian Sign Language. Okay, and then the division has started training and orienting various stakeholders and in the education space. You understand? So over time, we'll find individuals signing in various places. So there was a time when somebody actually criticized the kind of sign language that was used on GTV, okay, because it was not exactly what the people were communicating. Okay, so people got confused. That's why we have to come out with the Ghana-specific sign language. So these are some of the things that we are doing. But I will communicate your destiny to the divisional director, so that some of these are taken into consideration when we engage with our partners. Thank you very much.
Yeah.
Come again? If I should think so, but I can still check with the officer in charge and the director as well. Thank you.
The young guys, they're electronics. You want them to use anything, electronify it.
So a few things to clear up. So the number I gave for UNFPA is for gender and sexual-based violence. There isn't much of, they'll cancel you all right, but it's to report these cases. And then the AGO is mainly just to ask a lot of questions, etc. So please don't jump the UNFPA line for asking questions in case somebody really is in an emergency situation. And so that one is for reporting emergency situations. And the AGO would give you more information on the sexual and gender-based violence. And the issue of disability, right? I wanted to mention it before. So I know that the survey, I think he made a comment that they couldn't find people with disability, but I know we have the Ghana, I think maybe the name should be changed a bit, but the Ghana Blind Union that you could have reached out to, and then the school for all of them. Yes, exactly. Yeah. So these are people you could have reached out to. And secondly, about disability is that sometimes we have the notion that people are born with disabilities. We should also note that we acquire disabilities as you grow. So you know that maybe your grandparents have difficulty hearing, right? And for us, the age for difficulty hearing may even come lower because there's so much noise all around us, right? So when we talk about person with disability, sometimes we think it's so far from us. I wasn't born with a particular disability, but you can acquire it along the line. And I've had people like that. Somebody who was 21, she could hear, and then at 10, she had an illness, and then now she couldn't, right? And she comes to a health facility, and she's seated there, and no one can attend to her because they cannot sign with it. And that actually what inspired me to learn sign language, although I ended up learning the wrong one, because I got to know that Ghana sign language is different from the British sign language, is different from the American sign language. So please know the one you are learning so that you know how to communicate with them. Thank you.
If you have any contacts for child rights, child abuse reports, like, or you could report that as a sexual and gender-based violence.
So should I? So she actually gave the numbers she gave, the DOVSU, there was one on, I think, child protection as well. She gave those numbers out, so maybe you can ask from them. You can also call, they will direct you, because this is also under just a moment, Ministry of Gender, Children and Social Protection. So when the number I gave for UNFPA goes to the Orange Support Center, which is under Ministry of Gender, Children and Social Protection. So based on the situation, they will redirect you, right? And she also gave some numbers along those lines. And then if you want information on sexual reproductive health, you want to ask questions, etc., then you can go to the AGO platform, and then you'll be given the information.
All right, thank you.
So apart from asking questions and reporting through AGO, Orange Center, all of that, YMK, remember, the Ghana Health Service facilities are there to provide the actual service to you. So don't just report and say, of course, if you are hurt, you need a health service to take care of that. So don't forget, and tell your friends, okay?
Thank you very much. I am saying this because I reported a case of child abuse recently, and I called and called and called and emailed for like a week. Just one of these toll-free numbers for like a week, and nobody responded to my calls or my emails, but it was ringing. I don't know why.
Number of them around. I mean, the number of NGOs do have that. I know PPAG has one. I know that UNICEF has one. We, the UNSP, we have one. Quite a number of them. So you need to know the one that you call. Then we can be able to check why your call was not responded to. You get it? So let's have that number, the number that you called that did not respond, so that we can respond to it appropriately. Thank you.
What's the name? Shakira, right? Shakira. Okay, so Shakira, are you in school? Oh, yeah. Okay, so for whichever school you are, if anything like this happens, please report to the school-based guidance and counsel coordinator. Come again, you are at the university. Then the university will have a lot of opportunities. Oh.
Actually reporting on behalf of a kid, like less than 6 years old.
So and this guy is in the school, right? So please report to the guidance and counsel coordinator in that school, or if you like, this is director of education. That they to be taken up. Somebody must hear this, definitely. Please.
Thank you. Okay. No, please. Okay, so the number I called was from an organization called Child Rights International. Yes, an NGO. And the number is 030 27 90 703. I called this specific one because it said Child Rights International. So I thought that this is nothing relating to SGBV. So why don't I report it to like people who are okay, 030 27 90 703. Should I give you their email too?
Okay, I just want to also add that in the interest of strengthening government systems and making use of government structures, the Department of Social Welfare, which is located in every district in this country, takes precedence when it comes to reporting issues of child abuse. And so the Department of Social Welfare under the Ministry of Gender, Children and Social Protection. So you need to find out if these numbers are failing, what district is the child in, and then find out where the DSW office, which is the Department of Social Welfare, to make such reports. There's a clear outline for dealing with such issues, investigations that need to go, and those people are more equipped from the state's angle to be able to deal with them. And they have connections with a lot of NGOs because NGOs working with children are mandated to work with the Department of Social Welfare. So if you're not reaching out to NGOs, the government institutions are more stable, and it is easier for you to walk into a DSW office and say, I have noticed this, can you investigate it and take appropriate action? Thank you.
So thank you very much. I want to acknowledge a prominent person in our midst. He's more prominent. He's the immediate past director of Family Health Division, GHS, Dr. Kofi Issa. All right, so we're going to have our last session, and can we give a round of applause to our wonderful moderators? And then we'll hand the last session to Madam Sharifa.
Good afternoon. Shakira, how many minutes do I have for this?
10 minutes.
10 minutes. Right. Beautiful. So my name is Sharifa once again, and I'm doing this on behalf of the director, FHD, Dr. Marion Okun Owusu. She sends her apologies. I'm moderating the session on drivers of adolescent sexual and reproductive health and rights in Ghana, take-home messages, and policy implications. So we already know the goals of the study, but here we will discuss the key drivers of the impressive ASRHR indicators Prof. And his colleagues showed us throughout the morning and now. And then we would encourage every one of us here to engage actively and share insights from what we've learned today. Right. So this is an open discussion. Can anyone elaborate on the key findings, or just something small about the key findings from the study? We've listened all morning. So let's see if the messages have gone down, or we have taken note of the messages. May I name Dr. Divine to take the lead on this? Yeah, the key findings.
The key findings
of the study.
Okay.
Can you discuss some of them with us?
Yes, okay, fine. Thank you. I think for me, one of the major findings that I got from one of the major information I got from the study is that one of the major drivers is integration of services. So those of us who are service providers, we really have to look at how we integrate our services, especially for the youth. One area that really is a challenge to the youth is for them to be able to make entry into the facility. So if they make entry into the facility, they want to have all their services taken care of. So They don't want to come to the facility and then you tell them that, oh, this one, we provide only this one, the other one, go to this site. No. They want to have a flow chart that the facility is mapped in such a way that you can move from one area to the other and have all your services done. So that is one key thing about the integration. The other one is about the peer-to-peer influence, that they have on each other. This is something that we know in the ages past. But then it looks like it's still very important, and so we need to look at it well as to what is it that we are spreading around. One other thing, I see that in the past, peers are more of friends who speak to us, tell us what to do or what I do. I remember when I was growing up and I was in science school, I was from a home with a Christian background, being a ninth born, from the same mother, same father. My colleagues, especially the young guys, the boys, one particular guy, keep on worrying me. Have you done it before? I said, no, I haven't done it before. You have to do it, it's nice. And then I remember one vacation I came back, I think that was after Form 5 or so. I came back and I told him that I've done it. He said, hey, have you done it? So he wanted me to describe it. I failed. So he got to know that I couldn't do it. So the point is that in those past, it is actually your peers. But now, peers are more than your friends that is around you. It's more, TikTok sometimes become more of a peer than any other things. So we need to see how they get a lot more influence with this social media that becomes more of a peer to them than other things. So basically, this is what I have some other issues, but then I think let me leave it here, except you want me to go on.
Please go on.
Okay. So we have to look at that so that we can be able to help them. A lot of them have access to social media, TikToks and all those on. Quite a number of them. My sons, they have them. Some of them are chats, they have names and all that. So, and all of them are, they move from one area to the other in terms of the scope. They do almost everything. There's pornography and everything, all of them. So we really have to look at it and see what is being exposed to them for them to understand and utilize it. The other one, which is very interesting to me, is about education. Education, we know, is very key in driving down fertility, or delaying it a little bit, so that the women become mature, they know what they are doing, they decide on when to get pregnant and how to get pregnant, and then also when they are pregnant, they know how to take care of themselves because they have been there. And so education is very key. Unfortunately, we still have quite a significant population of ours that are not educated, but I think the free education program that we are having is really, really very important. It's one key program that, as a country, we really have to support and make sure that it is done well, so that we can have a lot more of the ladies in particular in schools. The interesting thing is that in relationship, at those early stages of relationship, most often the driving force is from the boys. We the boys, we are the one who wanted it. And we have all the means. We want to, find means to make sure that, we get it. And so if the ladies are educated, they spend time on their book, they know why they are there. I would say that my daughter looks quite programmed. She knows exactly what she wants to do. I remember when she's in school and she's come home, she really comes home, she wanted, maybe she has a lot of laundry to do. She will come home, come and pick a car, quickly go back to home, and then immediately she get home, she's in the place that she's doing the laundry. Go and see my boys' room. They are all over. So my point is that we need to see how best we can push the ladies in school so that we can delay the time that they spend, loitering around. The thing is that if the ladies don't have anything to do, and then they can be, we can spend the time to have maybe this popular food, I don't know how it's called, Indomie. They can have Indomie with them, and then with that, it can lead into something else. And so education is very key for me. Peer-to-peer influence, which I've expanded that it involves the social media, and the last one has to do with the integration of our services in the health sector. Thank you.
Thank you. Yes, excited that he got most of our key findings, and most importantly, the integration of services. I've been on so many fora and they keep saying, Sharifa, now you're saying the corners are not working, all of that. I said, let's integrate services. But if corners work for you in your catchment area, that's fine. However, let's let adolescents have access to services through the continuum of healthcare delivery. Yes, Shakira, your hand was up.
Yes, so we've been blaming Ghana Health Service for quite some time now, and I want to applaud them for a great work. I actually took part in a survey recently where I was a data collector, and it's called Willingness to Pay Study by Total Family Health Organization. So this study aimed to see if consumers who consume family planning, either injectables or the daily pills, will be willing to pay should the subsidies are removed, or if their prices were increased, either a bit or. And so the study showed clearly, at least from my side, a lot of the young women I interviewed were willing to pay. They said, you know what, we need the service. So if I have to, let's say, take the injectable 3 months for, currently it's 5 cedis. So if it gets to 15 cedis and I need it, why not? Like, I will still. And then we also realized there was a question where they get to choose as to whether they would choose a private facility to a public facility. And they said they would always go to a public facility, which he also trained, so.
Thank you.
Yes. And then the private facility included the quality services and also how they were approached. So, and we asked them, so aside that, what would you do? Some said, okay, if the prices increase, I would just give birth, like the married ones. They said they would just give birth. Others said, by that time, I would have been in my menopause and I'll stop having sex.
Oh. Really?
Yes.
We pray not.
Yes. So, and then I was just happy how they were all like, how do I say? They were just willing to say what everything we asked them, they were just willing to say it. And I think it was the facility personnel, the one in charge, the midwife, she made them comfortable. And then I liked the way she was conversing with them. It was just so nice. I was like, oh, I should also go for some.
Thank you. Any other? Because of time, I would ask a question. I'll ask USAID and GES first, then others can join in. Yes. So the question is, what are the most significant challenges adolescents face in Ghana? What did we learn today, and what else wasn't captured? Specifically, what did we learn today that are the most significant challenges? Who goes first? Teacher. Yes.
I think that listening to the conversation going around today, where's Vera?
Vera has left.
She's
Oh,
gone.
Vera.
Okay. Vera and a few friends think that GS can do more in the area of sexual reproductive health, and that we should be able to extend our conversation with our students or learners on the provision of intense services that we think that we do not have the expertise, but we rather want to refer to the appropriate quarters. And so as I sit here now, I want to still maintain that position, but I will engage, but I will have a conversation with my director and then possibly with the key management people to see how this will pound out going forward. Yeah, so yes.
Okay.
Sharifa.
Yes, sir.
You know that we'll be meeting, so when we meet, we'll talk at.
Okay, sir.
Thank you.
Yes, sir.
I think, so because you said the most significant, I think that
We can't hear.
Hello? Hello?
Draw it a bit closer. Yeah.
Hello?
Yeah.
Can you hear me?
Yeah.
Yeah, so I think because you spoke about the most significant, I'm happy GES spoke about education. It started the discussion. The research pointed us to that as something very significant. Education is the biggest driver from what we saw. And so I think just the integration is very key, and we have to look at it. To throw this to the national document being drafted, the Ghana Family Planning Costed Implementation Plan, you realize that there are actually strategies that are put in place to ensure that you actually have intersectoral leadership engagement, and for various sectors to include some form of family planning, or at least have that sense in their work planning sessions. Appropriately to also get to report on such, a broader stakeholder engagement platform. So that kind of engagement is very crucial. What is it Shakira spoke about in relation to the total family health activity? It's talking about the fact that we understand that donor funding is dwindling, and obviously if it does, as it's going, we understand that there's the need to segment the market. So is a project by USAID, funded by USAID, called the Total Market Approach.
Hello, please, can we have your attention, House? Yeah.
That is called the Total Market Approach. Okay, so that bit of the work is the Total Market Approach. And it seeks to segment the market so that you have the private sector playing in the space, all right, providing services. If you look at the GDHS 2022, you will understand that a lot of methods were picked from the public sector rather than the private. So, for example, in this same national document, you would see that there is an approach to bring in the private facilities. But on the total market approach, you want to see how people can actually pay for the services, because at the government level, public facilities, almost it's kind of given for free, and people who can pay will still go for it. All right. So how do we segment so that those who can pay or will pay? And then once we have the private sector coming in, people understand that it's also my health, I'm willing to pay for it. And then we don't have the free, which, saves us from overly depending on donor funding. So I think it's something we have to look at, and we are supporting that work.
Right. Any other contribution to this? Yes.
That's to forget is the fact that we had problem, maybe as a nation, the youth do have the same problem. Sorry, this animal is worrying me. We as a nation, we do have this challenge, and then the youth is also having the same challenge. And I think that challenge is what it is about, how we communicate issues of sexual growth, rights, and things in in a family. That is parents and their children, especially when they become adolescent. How do you tell them that, okay? There was one time I asked my son, where are you going to? Where are you going around this time? He said, oh, he's going out. Where are you going to? I am not too sure. I said, when you're going somewhere, I'm not too sure, then make sure that you have condom. Then my wife was looking at me. And then I said, okay, I said it because I don't know where he's going to. So I want to be sure. So my point is that Ghana Health Service is doing something that is quite good. But I think these are issues of communication. We have to find, this is not really health. It is issue of communication. I mean, it has to do, I remember when we were having problem with eradication of, what do you call it, this disease that causes the river blindness. There's onchocerciasis. We have done everything until we brought the social scientists in. And then they went to the field. I mean, after a while, they really help us to be able to get through to the people. Because people thought that what is making them blind is rather the medicine that we're giving them. That's what was their belief. But when they got to know that, no, it is a disease which the medicine is supposed to cure. If that disease is gone, they will not have the blindness. They started taking the medicine. So they collect the medicine, they throw it away until that. And then other problems that they were. So my point is that we need to let the communication unit to look at this, how this can be communicated in marriage. So that's my last comment.
Right, so I'll take the last comment for this. We'll move on, but we'll come back for Q&A. So let's take the last on this, then we can move on and come back here.
Okay, so I got your question as what are the challenges adolescents are facing. And I think that to simply put, one of the things that we mentioned was youth or adolescent-friendly ASRHR services and information, access to those services. And it brings our attention to the role that educational institutions, family institutions, societal institutions play in providing those information and services. Because when we look at the age group of people we are dealing with, predominantly spend their time, majority of their time in schools. And the school provides education, and then the education is supposed to be holistic. So just to add to the conversation about what is a challenge, that access and the gap that exists, because you are less likely to find adolescents in a health clinic, but you are more likely to find an adolescent in a school. The next thing is also about the challenges or distinct challenge of adolescents with disability and their access to these same services and information, and how, again, these same institutional structures from education, society to religion is structured in a way to address that gap. So this is another unique challenge, and I like that in our discussion we realize that we need to even do further research on the unique challenges that these sets of people face and how we are able to deal with them. So ultimately, it boils down to access to the information and how we need to collectively contribute to providing that information as parents, as teachers, as healthcare professionals, as religious leaders. Thank you.
Thank you. Remember I mentioned that there's an activity or a study the fathers were not getting involved, and the men, especially at the back, wanted to, yeah. So, so those studies, we have two of them, and one is using behavioral science. Yes, so in one of the studies, we are using behavioral science to actually improve access to contraception, especially condom. And TFHO came in handy to support with some condoms to pilot at places young people said they convene. As you said, when we asked them, they said, oh, if you can bring the condoms to betting centers at subsidized prices, we will buy. We took condoms to 3 districts, and they were gone. With immediate effect, yes. And I think someone mentioned going to the health facility for the free condoms. In the study, young people did not like the free condoms, the no logo or be safe. They say it's hard and all of that. So, so they preferred the scented, the thin. There are some condoms, doom saw, the dotted. Yeah, we had all of those. And it brings excitement to the game. Yes, and Rough Rider and all of that, exactly. So I think more and more we should know where they are comfortable getting the condoms and the type of condoms. Because for GHS, we don't even produce the condoms. It's UNFPA that supports with those of condoms or other contraceptives for young people. Who is Selassie? Selassie is not here. And I also thought that was Selassie, but he's not the one. Yeah. So we will move on and come back for Q&A. The next question will go to National Population Council. It will go to UNICEF. It will go to WHO. Please. Is it only academia that is at my back? Oh, MOH. You answer first. So how have the recent policies impacted adolescents' sexual and reproductive health in Ghana? Prof and his colleagues presented on some of our policies, and I did same. How do you think we are doing per the study and what is known generally? Don't worry. Nana?
Thank you for the question. On the part of National Population Council, we have two key policies that we work with. So the first one is the National Population Policy. And in there we have some targets that we work towards in close collaboration with our partners. So some of the targets are on contraceptive prevalence rate and looking at how the trend has been from since we did the policy in 1994 and had it revised in 2017. Yes, we've realized that the contraceptive prevalence rate is improving steadily. In relation to the total fertility rate too, we are making progress as a country. The last time from the data that we have, GDHS 2022, we realized that it's 3.9. And we are looking forward that in the year 2034, we would have our TFR come to 3.0. So from 2024 to 2034, we are hopeful that with the work that we are doing in our various areas as partners, we would help to drive Ghana's TFR to the level that we all want it to be. And then on the programming side to National Population Council, we have collaborated with Ghana Health Service, Ghana Education Service, UNICEF, USAID, UK Aid to have a number of programs. The GAP project was cited in the presentation. And also You Only Live Once, YOLO, the TV series too, is something that has gone down well with the youth, and through that we have been able to drive down our messages on being assertive, being brave as to whether you don't want certain touches, you want this to happen in terms of your education, your career progression and everything. So in a nutshell, I'll say that we are doing a lot and there's more room for improvement. Thank you.
All right. UNICEF? Okay. Yes, ma'am.
Maybe we are taking this opportunity to talk about the ARH summit that we are going to have. Yeah. Anna.
Please, you pay for advertisement.
So for...
Oh, you are inviting us.
So
Okay.
as my colleague has mentioned, this year the Adolescent Reproductive Health Summit as National Population Council, we do it every biennially. So every 2 years we do it. This is the 4th edition that will be happening in the month of October. And this year we are focusing on teenage pregnancy and HIV new infections among young people and its implications on the SDGs, especially Goal 1, Goal 3, Goal 4, and Goal 5. Yes, so over there in our participants list, we have identified some youth with disability, the groups that have them on board. So we would like to open the discussion for these young people to let us know what actually that they want we, the policy and the programming people, to do for them when it comes to access to SRH information, and also how they are managing issues regarding HIV new infections. So in a nutshell, this year, National Population Council will be coming to you, our partners, and then invite you to the summit. Thank you.
It's going to be a hybrid, so I believe if you are not invited personally,
you can watch and enjoy. Thanks.
All right. So I think MOH is ready to come in, Madam Moderator. Okay.
Yes.
DG, so we're ready
Yes.
for you.
No, right now I'm Marion.
All right, so I think it's been a good initiative, especially with the steps that GHS and GES are taking towards that, with the policy documents currently being available, the job aids, as well as the training manuals. But I think holistically, at the national level, this issue should be taken up into the national policy level. That is probably having an adolescent health policy, reproductive health policy, and then actually designing a strategic plan to consolidate the effort that is already being done. With these things having key indicators, let's say a data dictionary of what we are looking at tackling. Let's say, for instance, the number of teenagers or adolescents who are accessing this a certain facility within a time period. So what we are recommending is that we take this up at the national level and then have a strategic plan for it to help with the consolidated effort so far. All right.
Okay, thank you. Before we move on to WHO, I think we have the reproductive health policy for the whole division. And before now, we used to have the adolescent health policy, but currently it's within the general RAMCA strategic plan.
No.
So, I mean, from findings and recommendations from this study, we could, the next session, tease out and have a very consolidated adolescent health strategy. Thank you.
All right, I think I look forward to engaging you further on that.
Give us money.
Please
That's
don't give
the
us
most
money.
important
Don't bring
thing.
that up.
Give us money.
All right, thank you.
WHO.
Okay, thank you very much. So, for WHO, I think over the past years, we have supported especially supported the Ministry of Health and then the Ghana Health Service to actually build capacity over the past few years. What we have done is to actually build lots and lots of capacity of service providers across the country with respect to nurses and midwives on adolescent and youth-friendly health services to ensure that quality services are being provided across the country, and using various models and approaches in building these qualities. And I believe that we've also supported the ministry to lead a high-level technical group to actually sign a commitment on adolescent health and well-being, which was even presented at the 75th UNGA, the World Health Assembly, on Ghana's commitment to adolescent health and well-being. So we have over the years supported the adolescent health program to actually do some of these interventions. And also some of the interventions like the WHO web-based platform have actually given voices to young people at the end of the day, could really provide a feedback on the services, and has also led to quality services being provided in some of these health facilities. But again, with the reports that we have seen here today, we've seen that there still needs some things to do, especially with our adolescents living with disabilities, that we need to ensure that services are also reaching them. And I think it's one of the things WHO is working to mobilize some resources to continue to support the Ghana Health Service and the Ghana Education Service to be able to reach these marginalized and then adolescents living with disabilities. So I think it's something that we will be looking at in the near future. Thank you.
All right, thank you. We'll have the last speaker for this from UNICEF.
Okay. It's not coming over. Okay. Thank you. So I think in the last 2-3 years, and it's still ongoing, from UNICEF's side, our adolescent program has been first on the safety net, That's the children that are already pregnant. What can we do for them? So UNICEF has a program called the Safety Net that we run together with the Ghana Health Service to make sure that they go through safe pregnancy and delivery. And then after that, one of the policies that between Ghana Health Service and Ghana Education Service has instituted is the back to school, so that the adolescent can safely get back into school, although it's not very popular with our, how do you call it, community leaders. But it also helps to empower these adolescents so that they don't lose out on their potential. Then we also have the social and behavior change activities that we are undertaking to increase uptake of all the fine adolescent health services that the Ghana Health Service have in their policy or implementation plans. One of it, Sharifa talked about it, is the behavior insights implementation research that we are undertaking. And that's where the condom distribution to young people came on board. It's in the pilot stage, and when we end it, we'll be able to advocate for the Ghana Health Service to scale this up. Then we also have the human-centered design implementation research is also being piloted in the Ashanti region for parents and guardians, as well as service providers, to engage more with adolescents and to break the ice so that they will be able to communicate, especially about sexual and reproductive health. Alongside that is also mental health, how do you call it? Mental health counseling, where we are not necessarily engaging health workers, but lay leaders in the community. That is pastors, queen mothers, and some assemblymen, and so forth, to help us in doing this. We also have advocacy with gatekeepers through our CSOs that we have partnered with. It looks like most NGOs work with the adolescents themselves. But when it comes to whatever empowerment they have given them, they have to do this in their homes. And if the parents don't understand what is being done, then there's a challenge. Sometimes it's not even the parents. Sometimes it's the church leader or the imam or the community leader, and the parents will get into trouble with them. So the advocacy is at that high community level so that the adolescents will have the enabling environment for them to practice whatever empowerment we have imparted onto them. Then we have the tech platforms, that is the AGO platform, and then the Savannah Signature She Plus platform, and then also the talking book for communities that have no light but can use these small devices to receive information and education on some of the issues that bother adolescents. They can equally record their questions and their concerns on these tech platforms, and then they are addressed at the end of the day. Apart from this, we support the Ghana Health Service wholly in its adolescent services so that more young people can use or utilize the service. So the mental health was one of the key ones that we saw that utilization was low. And then, you know, with all this Indomie and fast food, NCDs are also, that's the non-communicable diseases, they're also creeping very fast on our adolescents. And then UNICEF also has the GIFT program, that is the Girls Iron Folate tablet supplementation that is done both for in-school and out-school girls, so that we can augment their HB levels and not make them anemic. So these are a few things that are ongoing in the UNICEF space. Thank you.
That was a longish one. Thank you. Yes. Now, finally, to our adolescents here. What are the barriers you face and the rest of your colleagues face in accessing reproductive health services? What did the study say? And what do you face that the study did not say? Yes, yeah.
Okay, so concerning the barriers that prevent us from obtaining education, one of them is stigmatization. So sometimes we get stigmatized when you want to obtain information or education about reproductive and sexual health. And more of a parental constraint. Maybe your parents they'll be too strict and wouldn't like to elaborate on adolescent sexual and reproductive health and rights to you. And health service challenges. Maybe to obtain education or information would be too expensive for you to access. So those are some of the barriers that prevent us from getting information. Thank you.
Oh, it will interest you to know that the education is free. Or maybe it's the lorry fare.
Yes, yes.
Are you sure?
Yes.
The information is the lorry fare to go and get the information.
Yes.
That's why the YMK is there. Do you have a smartphone?
Yes.
And you have a YAM. With Ago, you can call with your YAM.
All right.
The YMK, you use your smartphone and you get a service provider. So tell your friends and let them tell their friends that it's not all the services that you need to go see the service provider. It's just a way to cut the cost. Okay.
Thank you.
Yes, you're welcome. Any other?
Madam
Young
Sharifa,
people, yes.
Please, is the YMK app on
Google. We are now developing the iOS version.
Oh,
Google
okay.
Play Store.
Because I tried downloading and
I'll give you the APK. You can download it easier with the APK. Are you using an iPhone?
Yes, please.
No, not yet. But we are developing the web platform for the YMK. We are doing that with GES. And very soon, you see, funding. If we get funds, it will be live very soon. So you can use your iOS device to go online because it will be web-based.
Okay.
It's in the pipeline. Yes.
And please, I also want to ask if the YMK app contains thorough information or education on contraception, because sometimes you meet with young people and then there's not just enough time for you to say everything about contraceptive or contraception to them, and so it will be I just want to know. So that's why I tried downloading the app. I want to know if there's enough so I could recommend it to young people that I know that need this information.
I cannot tell what's enough for what age of the person using the app to access contraceptive information. But what I can say is that there's a service provider online. If the enough we have there is not enough for you, you can still have a chat with the service provider online to get that information for your colleagues or for yourself. Any other? Hetty, I haven't heard anything from you. Yes.
I was having some tete-a-tete with the representative from GES. So we've provided you with a lot of platforms and a lot of information, right? And as Sharifa rightly said, you are ambassadors. You have to take that information out. But I actually, Sharifa, please, how long do I have? Because I can go on and on.
You talk, I'll stop you.
So for me, I want to switch it. One person spoke about what the study did not cover, right? I want each person, I want to hear everybody's voice. Let's start with those who have not spoken yet, because you didn't come here to just fill seats. Each person, don't say the same thing someone said. Each person should say, what was not covered. Just, we can skip those who have spoken already. So each person. So we'll start with our guy in the one thing that bothers you that the study did not say.
It will probably be the strictness of my parents. Normally,
The guess of the parents.
yes, please.
Strict, they are strict.
Yeah.
Okay.
When I talk to them about changes that I'm going through, then they quickly change the subject or maybe tell me that they tell me that I'm growing, so I should expect it, but they don't really elaborate or explain it to me. So that's the only problem that I really have.
Okay, so the person in white, you've spoken.
For all you know, they don't even know
After,
how
let
to explain
those
it
who have
to
not
you.
spoken first go. Those who have not spoken first, I'm prioritizing them. Yes. In white.
Okay. No.
Okay, the guy. Yeah, I thought it was the lady. Yeah.
With the evolution of the AHD, there will be annual medical screening for based on the school side. So I want to know if whether it is accessible for the poor too.
You mean out of school?
Yeah, no, not like that. Is it free or they have to
The
pay?
cost of it.
The annual medical screening for in school.
Yeah.
Yes, so the student doesn't pay, but it's a paid for service by the Ghana Education Service.
Okay.
Right. So it's free to the students. It comes at no cost to the students, but it comes at a cost to the Ghana Education Service or the Ministry of Education. Yes. So you want same done for out of school people. That's
Yes.
your request.
Yes.
Okay, you've spoken to partners. They've heard you.
Okay. Thank you.
You have something else to add?
No, it's
okay. The next person.
Okay. For me, I want to ask, how are young people involved in decision making at the local level? Yeah, in terms of ASRHR.
We have representatives of young people at the GHS board or committee called YAC, Youth Advisory Committee. So unfortunately, the Greater Accra rep is not here. She is supposed to engage all of you or the young people in her region or appoint some young people in districts so that they feed us with their needs and wants and how they want services and other things to go for young people. So I'm going to charge Amadokas. You know her, right? Yes. So Amadokas will talk to your parents. Maybe your parents, they don't also understand how to explain to you the changes. Amadokas is going to liaise you with the YAC. There are even two YAC representatives, and then we will take it from there.
Thank you very much.
Okay, so I think everyone who has not spoken has spoken. So anyone has anything to add? Yes, the three of you.
Please, I wanted to know about this. Everything you were saying was mostly about the social media. For example, the You Must Know mobile app. What if adolescent doesn't have a cell phone?
You go to the service provider. That's one. The service provider comes to you as part of a home visit or outreach or at a hotspot. I think I mentioned those in the beginning, that if you don't have a mobile device to access our e-platforms, service providers still come to you, or either they are stationed at their corners or health facilities. So wherever or whatever is convenient and works for the catchment area or your district, it can either be a standalone or separate space clinic or just the general health delivery system. They can come to you as part of their routine home visits, or even in school as part of school visits, and lay counselors. And we still have the PSSPs, the peer-to-peer counseling, that can still refer you to a service provider. So encourage those who don't have mobile phones not to just sit and fold their hands. But we are everywhere. At least there's a CHIPS compound everywhere in the country.
Okay, thank you.
Please, you made mention of contraceptives, such as condoms. Please, is it advisable to, or is it always safe to use condoms? Or is it advisable to educate an adolescent to use condoms?
It is advisable if the young person is sexually active. We say abstain and you think you cannot abstain. You want to exercise your sexual rights, and we know that mistakes can happen and you may get pregnant or you may contract an STI, that's a sexually transmitted infection. Yes, we will educate you on condoms or contraceptives, then you make a choice of the one that suits your needs. So it's advisable, and you can talk to your fellow young people that instead of getting pregnant at this age that you are not biologically developed fully to carry a pregnancy to term and deliver, you don't have money to cater for yourself and your baby, you are eating from the house. There was a time a woman was in labor and her 13-year-old was also in labor. So she has 3 mouths to feed. Yes, I was there, I saw it, which is not economically prudent and even for your life and all of that. So yes.
Okay, but condoms also have disadvantages.
Like?
It can get best and
they can get best.
Yes.
Yes. So when we are educating you, we will say don't put the condom in your wallet or purse and sit on it. Don't put the condom there for so long because heat might destroy the condom. Do not use a condom that has expired. It increases its ability to burst during the session. And wear it well. If you don't wear it well, it will burst during the session. So there are terms and conditions to using these things.
Thank you.
It's a dual purpose. It will protect you from HIV and other diseases, and as well as not getting pregnant. So take note. Thank you.
Okay. But during the discussion, you guys only talked about the advantages of using the condom. You did not talk about the disadvantage aspect.
What's the disadvantage?
Yeah, that's why you left that one out.
No. So the best thing and the only disadvantage from studies, or because we've gone around asking people, is that they say it reduces pleasure. The thing is not sweet again when they use condom. And we are saying that no, that's not true. And people in this room have gone to the extent of making condoms that are very light, making condoms that are dotted to increase their pleasure, making condoms that smell like fruits to increase their pleasure. And the disadvantage you are talking of is the storage, as I said, and using an expired condom or not wearing it well. Do you get it? So they don't really come as disadvantages. It's the process of using the condom. Yes.
I've also heard that we have female condoms. So what if a male and a female are in sexual contact and they keep long? Would the female condom enter the vulva?
If the female condom is worn well and the penis directed well into the female condom, there's no way to fall or dislodge into the vulva. So that's why I said when you come to us, we will take you through how to use the contraceptives. We don't just give to you. And if you don't go to a service provider, take note, and you buy it off the pharmacy, you have the right to ask, how is it used? Okay? Because the female condom is some way, not like the male condom. There are 2 sides and all of that. Maybe this forum, Amma would call you again and educate you on that. But don't just buy a female condom and stick it up there. It may dislodge if you don't do it well. Okay?
Yeah.
Yes.
Before you continue, are there any questions that are related to sexual and reproductive health, like myths, etc.? We can address it afterwards. Maybe you can see me or see any of the people here or from UNFPA. Jigbadi is here. My other colleagues were here. Maybe they can explain to you further. I don't want to cut you short. I want you to actually come up and ask. But the firm was to ask you about the things that you did not see in there. I feel like we are deviating from that. Secondly, you mentioned a very good point, which is maybe as part of our take home as partners, that we should also emphasize the other aspects to using stuff, to using contraceptives, to having sex, to whatever you engage in. We should tell you the pros and cons, and that is something that we would also take home. So I'll still leave the floor to you, but if you have any myths, any questions, etc., we can address it later. Yeah. Sorry, just you asked two. Let him ask one so that he can. Yeah.
I have a problem with the adolescent health development. You said that I heard like they can have this counseling on social medias. So I want to ask that those who are like in the communities, like say like the Kaya is, like how would they be informed that like there is this counseling on social media? Because they'll be like, they are afraid that they'll be stigmatized if they join the public counseling.
Okay. So first of all, we need to ascertain that the Kaya is able to access a smartphone or the phone that is compatible with the online services. However, for Ghana Health Service, we do not deal, or we have not yet started dealing directly with Kaya. The CSOs that work with UNFPA, UNICEF, they do that on behalf of Ghana. So they send service providers to counsel or meet them. They have their meeting days and they provide those services. I mean, but if it's a platform where a normal YAM phone, I think that's GSM phone, can call, there are some of the toll-free lines that we can call. And I think my 10 minutes has become so many minutes, and I would want that we discuss some of these things after, whilst we are having lunch and all of that, so that we can move to the next session and people can eat. Some other people's sugars have dropped drastically, and I'm number one. Yes. So let's continue the discussion. As Hetty said, there are a lot more of us here that can help you answer some of the burning questions you have personally, and the other questions that the study, or you think the study didn't address, but you would want us to address. So I'll just encourage all of us that, as we've discussed the drivers of ASRH in Ghana today from the study results, let's take to our communities, our departments, our institutions, and let it guide us so that we can work better, that we know what drives SRH services. If we know you are a community worker, you need to engage parents to be able to communicate with their wards. If you are in the education system or even community, we know that keeping girls or keeping young people in school actually helps them to stay in school, not get pregnant early enough, and they are not prone to child marriages and all of that. And once again, we need to integrate our services, and we should have people like you having peer-to-peer counseling and education for young people. And today you've been privileged to be here. You've heard a lot and you've learned a lot, and you still learn whilst we are out there trying to catch up, eat and all of that. Do not just put the information in your pocket or purse and sit with it. No. You are supposed to be ambassadors for your colleagues. We couldn't have called all of you here. So you are the mouthpiece of the young people in your communities, all right? So go back and don't disappoint us. So, Madam MC, I hand over to you. Thank you all for listening.
Thank you, Madam Sharifa. Okay, so like she said, we are almost there, and so we'll have our remarks, a closing remarks from our young person, Deborah.
Sorry for the delays. I thank all the presenters for a wonderful presentation and all the moderators as well. I feel very privileged to be given this opportunity to give remarks on behalf of my peers concerning what we've learned as adolescents, how it will help us as adolescents, and how we will use it to help other adolescents. To commence. To commence, I've learned that there are some factors that affect the roles of adolescents and how in relation to their reproductive health. And the first one is cultural rights and celebrations, such as puberty rights, example, Dipo. Some people, it has negative and positive effects. And the positive one is that it restrains them from having an intercourse at an early stage. And the negative one too, or the negative part of those rights, cultural rights, is that it makes adolescents feel grown, so have their liberty to have intercourse at an early stage. And the second one is the contemporary issues. This one is the current issues we are facing, such as the Valentine's and the rest. It gives adolescents an opportunity to engage in all these kind of things because they feel the Valentine's Day is for us. And regulatory role of traditions. Sometimes some traditions forbids early intercourse. That's the family of the adolescents will buy some things, such as maybe cements, when they engage in those kind of things. Okay, so to continue, there are some barriers that prevent adolescents from getting information. That is stigmatization from either the peers or the nurses, the health workers. So sometimes adolescents they are not at liberty to have information because they are afraid the nurses or their peers will stigmatize them. And also parental constraints. Maybe their parents are too strict and we are not having that kind of communication with them. And also health services challenges. And also it was also said that ways by which, okay, so adolescents also engage in all those kind of early and premarital sex because of economic dependency. So some parents coerce their wards to engage in those kind of things in order to gain income. And lack of open communication, maybe with the mass media or their parents. They have inadequate communication with their parents in relation to their problems faced as adolescents. And also peer pressure. They try to mimic or imitate their friends and all other kind of things. Maybe new fashion and the rest. So they try to emulate them in order so that they will not be left behind. To wrap it all, I thank you all for your cooperation to make this gathering a successful one. Thank you.
Thank you very much, Deborah. So, my bad, we didn't start with an opening prayer. However, may we get to our final destinations in God's name. I'm praying, though. Nobody has said amen. May we get to our various destinations in God's name because we didn't start with an opening prayer.
Amen. And may the food be delicious.
Amen.
Amen. So now we can go for lunch and then from here we can depart. Thank you.
Anyone who hasn't picked? Yeah. Lunch is ready.
But you must hustle if you want job. You no finish, they won't fight us. If them they run, them no fit catch up. I know they form say I too righteous. No con they form say you too like us. Me no get the time for the hate and the bad energy. Got my mind on my money. Make you dance like broccoli. Steady green like broccoli. Steady on my grind, oh yeah, what they want telling me. Could deny my fantasy. They want to check if my tap ain't no wrong. But it they rush well, it be much. Now gotta make my tap it the rush. The kind money we touch, yeah. It they rush well, it be much. No be hype, everybody they crush. There's no darling with us. You fool me jackpata, I dey go Ghana. You never thought you dey from papa. Which kind money we never see before. Cause hello me, got me feeling I'm the one. Ajay. They never take my cake away. Ajay. You can't count my grace. I just did my lane. Me no get the time for the hate and the bad energy. Got my mind on my money. Make you dance like broccoli. Steady green like broccoli. Steady on my grind, oh yeah, what they want telling me. Could deny my fantasy. They want to check if my tap ain't no wrong. But it they rush well, it be much. Now gotta make my tap in the rush. The kind money we touch, yeah. It they rush well, it be much. No be hype, everybody they crush. There's no darling with us. It they rush well, it be much. Now gotta make my tap in the rush. The kind money we touch. It they rush well, it be much. No be hype, everybody they crush. There's no darling with us.
And I've been living fast life, but I see it in slow. Oh no, and you see my lifestyle, I got G's in the dough. See many people they outside where they feed man door. Oh no, and me I stand the defender like Joseph you. My girl say she want Netflix and chill, so I chatty get if I want it. If you fall in love, get it certain. You go to breakfast, I'm not happy. Can you see the pool, I'm not catching. I'm not faking this, no fugazi. You see these feelings, I'm not catching. I'm on quest and feet, I just want it. If I go to my business, I'ma show you right. All I get for the night. If I go to my business, I'ma show you right. All I get for the night. I find it excessive. If you want to go on the generous me. If you want to take a serious, I do top speed. No fit to resonate, I'm on a different frequency. I don't think it's necessary. I be damn just somebody that can do like me. When I feel like Musala coming up the right way, I can't tell you different, but you don't know to tell me. You know, say me, I'm a it's me, I got money past you. If you're not careful, you know, say me, I'm a if you ain't got money past you, if you're not careful, if I go to my business, I'm a all I get for the night. If I go to my business, all I get for the night. If I go to my business, I'm a all I get for the night. If I go to my business, all I get for the night. body, back shots. Give a body, back shots.
The way I jump on NYC, big energy got the best acting. Steady, acting. Sweet in my belly, you like cake and something. Eggplant emoji, so train when I slide it. Now she watching me like daddy. Sensational. Waiting time for you, girl. And I know. I'm a presidential review goody, I get it now. Put me on fire, get it so divine. And I want that woman you so sensational. What's in line for you, girl? And I know.
tó ń ṣe ní kọ́lọ́ ṣe ẹjẹ́ lẹ́nu ọ̀dọ́ ìṣe alábìnrin ọ́fíìsì yépa yépo àṣàmọ̀jì ọ̀gá lọ́nà fọ́ọ̀mù kọ́sárì microscopy as you can see àbísọ́lì ìjà kọ́ọ̀mù.
But your birthstone, you an earth tone. I'm missing in you, baby, come on. You want me make it happen, baby, I know. Want me to keep you happy, baby, I know. Penthouse, condo, don't know one, I'm a piano. You want me make it happen, baby, I know. I'm here to make you smile, we feel oh, happiness,
happiness, my life no stress, family no mess,
happiness. Your life no stress.
Go on you, I gotta see your life.
say make her rest more. As me I wake up, now she did my mind don't walk. Then one day two, one of you folk go was. Now so me I go down, say make we link go walk.
Got my hand on your heart now, I can feel it race. If I leave, then you say you can never love again. Wanna give you it all, but can't promise that I'll stay. And that's the risk you take.
Baby, calm down. Yo, this your body, it puts in my heart for lockdown, oh lockdown. Yo, you sweet life, phantom. If I tell you say I love you, you know they for me, young girl, oh young girl. No, tell me no, oh. Baby, come give me your lo. You got me like whoa. Shawty, come give me your lo.
I'm feeling vibes on vibes. I'm a ticking dynamite. I blow your candle lights. You know I'm just that type. No, them no fit kill my vibe. Them no fit kill my vibe. Them no fit kill. Them no fit kill my. Wise man said, follow the stars. There you shall find a piece of advice. If you hit your enemies shine. If you're not a friend of me, enter the light. Cause you can never kill my vibe. Got here with no sacrifices. Everything was taken, still had to make it. Vibe killer, me I no go take shit.